We could prevent infertility with proper understanding of the female menstrual cycle. The fundamental premise that I was taught was incessant ovulation is a risk factor for cancer. And so it's implied that women should be on birth control. And I didn't agree with that.
Dr. Naomi Whitaker, she is a board-certified physician specializing in restorative reproductive medicine. Dr. Naomi helps women and couples improve their natural fertility, extend reproductive health, and even enhance long-term well-being. So if the blood is brown when you're menstruating, that is not a good thing.
One day of brown bleeding is not concerning, but we look at the whole menstrual cycle pattern over multiple months, especially a consistent tail and brown bleeding of 3 days or more is a big red flag for inflammation in the lining of the uterus.
What about individuals that are having longer than normal cycles? What might that be indicative of?
Typically, the follicular phase is variable, and the luteal phase should be stable. So if you have that, it might be pretty good, even for a woman with PCOS. If she's having a healthy luteal phase and her cycles are 32 days, that's fine.
PCOS archetype, general nutritional advice that you would give?
Not skipping breakfast, high protein, being really understanding of yourself, that there's an adjustment phase and that cravings and binging and mood disorders, all that go with PCOS, and how you have to have compassion with yourself.
Biggest question I have, and I've not been able to get the answer for this, is why does endometriosis happen?
So,
all right, today I am so excited to have Dr. Naomi Whitaker with me today. She is a board-certified physician specializing in restorative reproductive medicine, a science-based approach that seeks to restore natural fertility and optimize hormone health rather than override physiology. With extensive training in advanced gynecological surgery, hormone restoration, and cellular health optimization, she works at the cutting edge of fertility and longevity medicine. Her philosophy is simple. Infertility is not just a barrier to conception, it's a signal and an opportunity to uncover deeper health imbalances. Through bioidentical hormones, lifestyle changes, advanced diagnostics, and regenerative therapies like PRP, Dr. Naomi helps women and couples improve their natural fertility, extend reproductive health, and even enhance long-term well-being. Well, welcome to the show.
Very honored to be here, and I'm excited to expand my knowledge base in the longevity space and hopefully bring new frontiers to the reproductive space.
Yeah, I'm so excited. When you gave me this kind of restorative reproductive medicine line, I was like, hold on a second. This is amazing, first of all, but I don't think I've ever heard anyone in any space use that terminology.
Yeah, so. It's very different, right, than what women's health has been defined in the last century.
Yes.
But I think in the moving forward, the future, like this century, with the mindset that people like you have, you see forward what the future is. And in the information age, I think we are thinking so differently and so much forward.
Yeah.
Right? Like we have all this information at our fingertips. So we're bridging that gap between what the patient wants, me as a patient, and physicians. In the past, researchers were in a lab, physicians were in the office, patients were at home and had no access to medical research. Now with social media, things are moving at lightning speed where you have access to the cutting edge clinicians implementing research that's up and coming and not just, there's a randomized controlled trial that was done decades ago and it's based on thousands of people and this very generic data was applied. Now we have people like you putting together the research, like, okay, and thinking about, okay, my parents had this risk factor.
Yeah.
And what do I want in my life? I don't want that outcome. And as our country is getting sicker, I think this is a response to, hey, what can we do better? Because we're getting sicker. And every generation kind of has their own thing where they rebel. And I think we're rebelling and integrating all this science and using the best of social media. There's a big downside, but there's a beautiful side where you can move at lightning speed with advances like this.
Yeah.
That's where longevity medicine is looking at the future, integrating all this data looking forward and not, okay, well, this was done 20 years ago and by the time it hits medical schools, it's outdated.
Yeah.
We're looking forward to what we can do in true preventative fashion, not, okay, a pap smear prevented cancer after being done to thousands and thousands of women, but that's not really optimal care.
Right. This is actually a great point. So you bring up the randomized control trial. And, I will say I feel super grateful. I feel like, so many of my friends are physicians, like 95% of my friends are physicians. And I don't really get much pushback on social media, actually, from physicians in general. But from time to time, there'll be like a researcher, a PhD or something to say, well, but where's the exact data on this specific thing that you're doing? And my rebuttal is always like, one, there's probably never going to be a randomized control trial on like optimizing my nutrient status from a micronutrient test, right? But it's also like, I would say it's almost impossible to do, even if you had the funding, even if you had the reason to do it, a randomized control trial on, let's even just use the topic of fertility, right? Because every single woman could have a different reason why they're struggling with fertility, and we're going to get into this. But so wouldn't you say that it's almost impossible to even do a randomized control trial on some of this stuff?
Right now, yes.
Okay. What do you think will change in the future?
So what we really need to do is subspecialize women's health more.
Yeah.
So gyne, OB, under gyne, PCOS specialists, and there should be subtypes of PCOS. Under endometriosis, there should be subspecialists and probably subtypes of endometriosis one day.
Yeah. When do you think we're going to get to that spot?
Well, it really depends. It depends on the power that patients and that take for advocacy. Because right now, we aren't really on the road to change. But I'm hoping with this information, with me being here and hopefully really having opportunity to explain what restorative reproductive medicine is and how it really is the precursor, in a sense, to longevity medicine, or it's really another path to longevity. Everything that you do when I discovered your content was completely in line with things that I've learned both in clinical practice and reading the evidence and common sense and outcomes. And so, of course, if it's good medicine, if it's scientifically sound, we will all get to the same outcome.
Yeah. Well, let's talk about, so you were trained traditionally, right? And during that, what did you learn that you still practice today or use today? And then what have you had to, learn on your own?
I've used everything, right? But I went into women's health as a skeptic.
Okay.
And so I entered medical school saying, the one thing I don't want to do is women's health, because I thought it would be boring. I thought it was going to be pap smears and STDs. And I thought, well, that just doesn't sound intellectually stimulating whatsoever. So what I really was looking into, endocrinology was on my radar, family medicine. And I always really liked working with my hands. But my parents are immigrants, are refugees. And so I never dreamed of being a surgeon. But it makes sense that when I found women's health, I was not intrigued initially until I saw what could be. I saw this little niche group at my medical school was practicing this way.
Interesting. That's
so
amazing.
I saw the contrast right there. And I saw just the standard cookie cutter model of suppressing ovulation. You go to the doctor, you choose A, B, or C suppressive medication in this clinic. And then I got to rotate with another group. And in the operating room, people were flying in from all around the world for this type of care to find all these answers, to get cured.
Wow.
And the contrast was astounding. People flying from around the world, from Poland, I remember because my parents are from Poland, to Omaha, Nebraska. Okay, people are flying from around the world. That means almost no one is doing this. There's a huge need. And this is so different. And I don't want to go into medicine to just do the same thing, to just follow an algorithm. I want to offer something more that no one else would offer. If I'm going to commit my life to this, be away from my kids for this, I want to do something really meaningful with it.
So was this by design? Did you find that school because of that? Okay, no. Did you just get lucky and happen to, because I feel as if in standard OBGY training, of course, like it's so critical and needed, but you don't always, most people aren't finding this like really niche group of people like offering curative solutions.
Yeah, that was the only med school I made it into. I was waitlisted at one or two other places and moved across the country when my husband was in Afghanistan. And I had a very open mind and I was very skeptical too.
Yeah. So maybe you were like called for this position, I feel like.
That's what it feels like. Yeah.
I love that.
And that's why I, I can get deeper into it, but I saw the lifestyle and how difficult that would be. And I never really intended to go into medicine to destroy my health, right?
Yeah.
And commit my entire life to it, days and nights. And that was just not the vision of, I never thought of obstetrics before. For example, it's a very, very taxing field physically and emotionally. And so I was very resistant at first to this idea, because I thought, well, I could do derm maybe and do work 3 days a week. And
okay, well, I'm glad you didn't go that route though.
I know. And then it kept going back, like, but if I'm going to commit my life to something, I want to do something amazing with it.
Yeah.
I'm kind of an all or nothing person too, so it makes sense. I couldn't just.
Me too, for sure. As you can see, as everyone here probably knows. Okay, amazing. Well, let's lay the groundwork. So how do you define this restorative reproductive medicine? What are a few of the key tenets of it versus maybe like a traditional OBGYN or even a fertility specialist?
Yeah, well, the fundamental premise that I was taught in allopathic medical school was that women are inherently flawed, that ovulation is a problem, that incessant ovulation is a risk factor for cancer, for ovarian cancer. And that just didn't sit well with me.
Yeah.
And so it's implied that women should be on birth control. That's basically Women's Health 101. And I didn't agree with that. And so the fundamental principle is that ovulation is healthy. And we should use cycle charting data to understand the female cycle, use that data, biomarker, biofeedback data, whatever you want to call it, fertility awareness-based methods, use this data to look into the body, to understand female health. And, women are not men, right? And so women are not the same on every day. So when women are lumped, well, women weren't even in randomized controlled trials, often because of our uniqueness, unless they were on birth control pills, basically. So we just do not understand the differences between men and women, and how women are more complicated. And so as a result, we were excluded in data, and there is very little information known about us. And so instead of giving up and just saying, well, let's just put everyone on a similar overriding medication, let's understand the body and work with it cooperatively.
Yeah.
So cooperate with ovulation, support ovulation, enhance ovulation, restore health and fertility. So work with the body, not override it or bypass it.
Yeah, I love that. Can we go back to that for a second though? So in medical school, what was that based off? Is there science to say that not ovulating
So
is better?
it's they went too far. So there is some data saying incessant ovulation, so uninterrupted ovulations, so many ovulations over a lifespan, is correlated with the increased risk of ovarian cancer. Now, there's problems with this data, right? Because that could mean a lot of things. That includes women who have infertility problems, or, so it's not a causation. There is some correlation. So I think it has to do with you're including a lot of unhealthy people in that population. And so you're going to have women with what you call luteal phase defects, or ovulation defects. So ovulation defects, or what happens after ovulation, the luteal phase, which is when you should have optimal hormones, balance between estrogen and progesterone. There is going to be a large subset of women in that population with luteal phase defects. It's probably luteal phase defects that cause cancers, an abnormal ratio of those hormones, or an abrupt drop of those hormones that cause cellular changes or cellular stunning, because there's something abnormal happening to cause cell differentiation changes. So it's probably more frequent abnormal ovulations leading to cancers or inflammation or all these other things, because female conditions, reproductive conditions, are overwhelmingly not managed, right? Not treated. We kind of give up and we say, well, we're not going to be able to cure it, so we're just going to override it. And, it has done good in certain cases. For example, reducing endometrial cancer risk for women with PCOS. There are benefits of it. There are benefits of pain management for women that need birth control. But is that really what they want? Or is that optimal? Or is that all they should be offered, right? So we're talking about reproductive choices to be able to attempt to cure. Essentially, we're attempting to cure these conditions. We believe women deserve restored health.
Yeah.
Fertility,
I 100% agree.
Curing infertility, restoring health, which in effect creates healthier pregnancies, longevity for the mother, healthier children, and longevity for future generations.
Yeah. It's wild to me that they wouldn't have a better grasp on who the study participants were, because if they had parsed out healthy ovulating women versus, then you had your
even for
answer.
thyroid data, they lumped in unhealthy people. That's why the thyroid ranges for TSH level are ridiculous.
Yeah.
A whole bunch of unhealthy men were in this thyroid study. So it doesn't apply to women, especially reproductive age.
Yeah. Okay.
So it's very common in research that these normal lab ranges are not optimal. These lab ranges that are normal mean life and death, not optimal. So that's what you have to think of. Okay, are these red flagged in my chart, because they're going to kill me? Or are they normal? Are they really normal? Or are they optimal? Really understanding that and being able to advocate for yourself through research for yourself.
Yeah. Yeah, which is, obviously not ideal that you have to do your own research. But yeah, I don't, I'm not looking at really any of the standard levels. I'm always looking for what is optimal and for me, right? Like based on.
Yeah, I think it's all how we frame it, right? Because as long as maybe you can afford going to someone that specializes in optimizing your health. Great. And you don't have to worry about it.
Yeah.
But if you don't have financial resources to do so, the beautiful thing about the internet is you can find hopefully trustworthy resources that will help you find out these answers for yourself and advocate for yourself if you have to.
Yeah.
Find a way. There's so many avenues now of restoring health. It's just a matter of, do you even know that you need to do it? Because if you're going to get a lab and your doctor's like, it's fine, but if you still feel bad, it may be that it's not optimal.
Yeah. Yeah, that makes sense. I'm so excited about AI in a lot of respects as it relates to like maybe democratizing access.
Yes.
But then there's the downside of these models are trained on the research that's out there, right, on women. I am excited that hopefully it'll gather, unique figures too, like your data or other, female physicians that are sharing more of a nuanced approach, because the only problem will be that if they're trained on data that's like, either not really there and then it's making assumptions or something, or it's wrong for women.
Correct. So it all has to do with the assumption. Where's the starting point? Most of women's health research is inherently flawed because it's assuming ovulation is not healthy. It's just it doesn't really understand what endometriosis is or proper treatment, or if they have surgery, it's often done poorly. Yeah. And so the outcomes are poor.
They miss a lot of it, right? Is that,
for example,
or maybe take too much and then it's like injuring?
So most OBGYNs do not understand all the appearances of endometriosis, nor do they understand how to be thorough.
Got it.
So yes, most OBGYNs, if they don't have subspecialized training, will miss disease, unfortunately.
We're definitely going to get into endometriosis because I have a lot of questions about it. Some women in my family have had this, and I'm kind of like walking along. I sent her your Instagram because I'm like, you have to look at this woman. But yeah, we'll definitely talk about that because I know it's a huge issue. It's also mind-blowing to me that we just seem to know nothing about it. It's like, how is this even a thing? But we'll get there. Okay, great. So going back to, the differences, obviously. So between what you're doing and potentially any other restorative reproductive medicine doctors, but I don't hear this term very often, so probably not many, as it relates to deep dive. So you shared with me that, you found some pretty incredible findings as you've done some of these deep dives with women, right? Whether it be like cancer or something else that's underlying and they weren't even aware of it, but they probably came to you, right? Because they started having hormonal issues or couldn't get pregnant. So what does a, new patient intake look like for you? What are you looking for? What labs might you be running?
Ideally, when a woman walks in the door, she has 2 months at least of cycle charting data.
Okay. And how do you like that to be presented? What device or?
Right. So I went to Creighton University School of Medicine, and so that's where the Creighton Model system was developed. And
Okay.
that's what I found.
Like,
Accidentally, right? Stumbled upon this gem.
great.
And I had my own personal journey at the same time, of course. My husband was Afghanistan. I was like, let me look into this fertility awareness-based method stuff at the time. And so I was looking into temperature methods and all. I was able to explore a lot when he was in Afghanistan and trying to experiment on myself, which is what you like to.
Yeah.
I mean, that's what I think of you. I'm like, you are showing everyone that you are the science experiment, right? In a beautiful way, in an amazing way. Like, you're living proof of this science, and everyone's like, wow, it gets to see it in real time. But I did that on myself. And
I love that.
do it all the time.
I've been told by a couple of my MD friends too that, N of 1 experimentation is actually the highest form because it's literally on you. So if you have data, you do an intervention and then your data improves, then isn't that like, I mean, I know that that's not accessible to everyone. So I'm excited to talk about all things, but interested your take on that. Like, I mean, N of 1.
I mean, ultimately, it does. So N of 1 can contradict a randomized controlled trial.
Yeah, of course.
Yeah.
Definitely.
So a case report, one case can't nullify a lot of evidence either in some ways, but you can be an exception to this rule, right? And kind of break that barrier of this rule. But
I don't mean like that would void something that a randomized control trial, but like if you are in a position to kind of do a deep dive on your own health and then try things for, basically it's like science that's for your biology, right? Because it's like no one else can really replicate that.
Absolutely.
So,
I know case reports are very, very important in medicine. And I think underrated. And that's another problem with doctors that are so busy and how medical school curriculum is designed. They overemphasize randomized controlled trials, and they're very important.
Yeah.
But those are very biased as well, with major limitations, right?
Yeah.
Because the individualized nuances of that patient are not included. And so you have to include N of 1, one patient and an exception. Is it different than that? So do we have a randomized controlled trial showing that endometriosis surgery doesn't work? I'm sure we do, because for example, those surgeons probably weren't top tier.
Yeah.
But do I have multiple N's of 1s that are the exception to that rule, that never needed a repeat surgery, that have a dramatically improved quality of life, restoration of their fertility? Absolutely.
Yeah.
So, that there are cases that are breaking that stereotype that is prevalent, right? So I think it's really important that as physicians, we get so busy, and so we just quickly go into randomized controlled trials, and that's mainly what's in our journals. And there is pharmaceutical influence for that. I think that's the beauty of clinicians that have been around for a long time, is they really integrate the smaller pools with the randomized controlled trials and have more of a balanced view. When someone's fresh out of school, they don't really understand the nuances of how to interpret research and individual cases, and they haven't seen a lot of those individual cases and exceptions to the rule.
Yeah.
And how that integrates into a bigger system. And it's really important to understand the fundamental flaws of the medical specialty that you're going into, right? And to say, well, what was the study design? What did they assume? Because everyone goes into research with a bias. And so you have a lot of confirmation bias in women's health. Confirmation bias includes assuming IVF is the best, or that's the end-all be-all of fertility. So you go into that, and most or a large portion of research is just about IVF. So if you only do that, and that's where your data is, then you're going to have confirmation bias and you're going to lose some opportunities to look elsewhere.
Yeah.
Because you kind of have blinders on. So the same thing with women's health research. I was so excited when an academic medical center near me advertised a trial for women with endometriosis using low-dose naltrexone. I don't know if you know about low-dose.
Oh, I've been on LDN for years.
Oh, so amazing.
Yeah.
And so I was so excited for that. And then I read the study design and they had to be on the pill at the same time. And I'm like, that contradicts.
Right.
And then, so you assumed wrongly that these women need to be on the pill. And now that will negate the impact of low-dose naltrexone.
Yeah. The bummer. Well, I mean, hopefully, we get better data in the future, and I'm excited for that time. But, for now, let's go back to what happens when a woman comes into your office. So,
oh, yes.
the 2 months of the data.
Cycle charting. So, formal cycle instruction with the Creighton Model system, which is the only fertility awareness-based method or natural family planning method. There's different, names for these. But it's biomarker data that's scientifically written down. So a woman would go, or the couple would go to a formal instruction session and multiple sessions with an instructor who was taught in this system. And so it's a language of the biomarkers.
Okay.
And so they sit down, they go through courses and then individualized sessions to make sure that they understand and they're charting appropriately. And this maximizes the effectiveness to avoid pregnancy, achieve pregnancy, or monitor health. It's a very versatile system. And so the CDC has practice guidelines for birth control. And being versatile, low side effect profile, low cost, it meets all of those.
Yeah. So can you give us some tips on what that would look like? Obviously, we won't get to do the whole coursework here, but is it like cervical mucus tracking? Is it temperature? Is it any wearables? Is it anything like that?
It's mainly cervical mucus.
Okay. So you would expect around what day, and then the discharge, I guess, what would we call it? Would that be the right word?
Cervical
change?
Mucus. So we have women check every time they go to the bathroom. It takes about 10 seconds.
So
when they
wipe on day one,
every
or
day.
what day?
You just get into the pattern of it and you don't think twice because you want it to be as accurate as possible. You don't want to miss one observation.
Okay.
It sounds hard. It's just getting into a habit, but it's not. It's just wiping.
Okay.
It's just when you wipe and paying attention to the tissue.
Okay.
And so every single time you go to the bathroom, you check on the tissue. You could even do a finger test on the tissue. And you want to observe the stretch. Is it clear? Is it lubricative? So you want to know the sensation, the color, and then you write down how many times you saw it that day and the stretch, for example. Okay. And also you want to objectively write down the bleeding pattern. Those are the two main parts.
Okay. So like duration, color.
So each day, so light.
Okay.
So on light days, you also want to check for mucus. So heavy days, you don't need to.
Okay.
But light days, let's say if you have tail end light bleeding, if it's brown, that's abnormal, especially if it's 3 days or more. Mm-hmm. You also want to be checking for cervical mucus because you could also start to ovulate or start to become fertile at the end of the menses if you're going to ovulate very early. So it's prospective data. Temp is retrospective data. So you want to know in real time on that day, am I fertile or not?
Yeah.
And that's how you're going to know the fertile window in real time. That's how you're going to be able to use that data and implement it. Temperature, it's positive. I already missed ovulation.
Yeah.
And so there's information in that. And if you want more biofeedback data, there may be some reasons for that, right? And that tells you, for example, there was some kind of progesterone rise. That's what the temperature is telling you.
Yeah.
But if you want the most accurate, more accurate than LH sticks, more accurate than Mira, more accurate than anything else, just no medical device, no femtech device is more valuable than your brain.
Yeah. Yeah, I totally see that.
Yeah.
I think that's important and it's great. So you said brown is bad. So if the blood is brown when you're menstruating, that is not a good thing.
So, 1 day of tail end brown bleeding is not concerning. Okay. And again, it's not horrible, but we look at the whole menstrual cycle pattern over multiple months. We're not talking about 1 month. I'm talking about ideally 2 to 3 cycles. When a woman walks in the door, I'm going to be evaluating things like that. Patterns, especially a consistent tail and brown bleeding of 3 days or more.
Got it.
Is a big red flag for inflammation in the lining of the uterus, for example. So necrotic shedding is going to occur if there's a lot of inflammation. So if you think about it, the uterus is a window into the body of health. So that we get a window into every month, our body gives us feedback. So not only do we see the cervical mucus, which is the most important point of the whole cycle, the quality, quantity, timing, all of that is telling us data about how our brain and our ovaries are interacting, which tells us a lot about other things going on in the body, but also the inflammatory environment of the uterus through the bleeding patterns. For example, premenstrual spotting is often a sign of low progesterone. Tail and brown bleeding is typically inflammation in the lining of the uterus, which could happen from something abnormal in the uterus, like infection, or inflammation from outside the uterus, like endometriosis. There are other conditions that I could get into, but those are the most common ones that I consider evaluating for, at least discussing, depending on the history, right? So I'm not going to say, I don't want everyone running out, oh my gosh, I had this happen one time. And it's more patterns in the whole picture. I never want to say one test defines who you are as a person. One cycle defines your whole reproductive lifespan. That's not how it works. That's why I don't like AMH too much, because you can't throw your whole person into one lab number at one time.
Yeah. I mean, this is the first time I've heard that AMH is obviously not a perfect marker, right? But I've also heard it's like the only thing we kind of have. So you seem to have differing opinions on this AMH. So I would love to hear it.
AMH, the only thing it's ever been proven for is a measure of a woman's response to IVF and how many eggs she's going to, how well she's going to respond to overstimulation.
So do you think it's not valuable at all?
I think the downsides are greater than what we can do about it. What actionable items are we going to do from an AMH? Okay, so if you have a really good reason, sure. But I think proceed with caution. Have a good reason. Are you looking for PCOS? It can help diagnose PCOS.
Yeah. Being high, right?
Being high.
Yeah. What do you call the threshold for them?
So there's different thresholds. 10 is definite, basically, PCOS. Over 5, you start getting concerned. And so I think there's like a 80% sensitivity. If I don't remember the data, but it's high over 5, and it's almost 100% near 10. So, that's kind of the range. And low AMH does not predict natural fertility. There's no data saying low AMH predicts natural inability to conceive naturally. We have seen, there are many, many case reports and case series of women with extremely low AMH conceiving naturally.
Yeah.
So it's going to just scare people.
Well, my only question would be is, let's say you're 25 years old or 26, and I'm also a data person, so I want all the data all the time.
I get it.
But I also want to, I love like this type of dialogue, right?
Right.
So let's say you're 27, you aren't in a relationship, you have no idea who your husband's going to be, and it might be, who knows how long until you could get pregnant. Is it valuable then, so you could at least, of course, so with the caveat that no matter what your AMH is, right, you could get pregnant, right, at any time, because you only need one egg, right? Yeah. You only need one egg, and that's all.
With lower AMH, it's only going to tell you that IVF is less likely to work and that you're more likely to conceive naturally.
But if you were in this position,
so
no, this is like a really important part.
What's the best data? Your biomarker data.
Okay,
your brain and understanding what the cervical mucus and biomarkers mean in your cycle length, your luteal phase. I understand the language of the Creighton Model system, biomarker feedback system.
What if you're 27 and have your biomarker feedback isn't great?
Yeah.
I'm just trying to like paint the picture of a world that because you're right. I would want to know.
Exactly. You're right. So Dr. Natalie Crawford brought this up. You don't go to a fertility clinic until you're a failure. That's horrible. No. Yeah. What's beautiful is every woman should learn the Creighton Model system, in my opinion. Every woman should understand her biomarker data. That's the number one thing that you can do for yourself. A woman walks in the door with her Creighton Model cycle data to someone like me, or even a cycle teacher, a Creighton instructor. They have been taught for 18 months, dozens of women. They've been interpreting. They have intense supervision and tests to understand. They are these biomarker data experts. They exist out there.
How many?
Fem, Neo, Creighton. Thousands.
Not right.
Thousands.
Okay, that's good.
And they're available on the internet.
Yeah.
So, and if you want to invest, they typically cost very little. Unfortunately, I think they undercharge. There's a whole nother issue. And that's, if they could charge a little more, I think there could be a lot more access to this. And I think every woman would benefit actually, my daughter has already been taught, she's 11, about biomarkers, and she's not even cycling yet.
I love that.
So, and I have endometriosis, and I told her, I have endometriosis. This is what it's in. Surgery is one option, and these are things we're going to be talking about. If you have these issues, if you have these biomarkers, if you start to have cervical mucus, then you know that your cycle is going to start before you could predict your first period. How much less traumatic would that be for teens? So as soon as this should be technically in sex ed, right?
Yeah.
We know that men are fertile every single day. They don't need much in sex ed. We need more.
Yeah.
I want more in sex ed. I want to teach young women cervical mucus, cervical fluid, however you want it, cervical flow, whatever we need to do. There are Creighton teachers that have made classes for teenagers and young women to make it more less weird for them. But they can get a report card of their health right away. I wish I had that when I was 13, because I had a lot of problems, and it would have spared me a lot of misery and shame.
Yeah.
So and I've had young women come to me as teenagers, and we've been able to find endometriosis early, and that's very controversial, but it is easier to treat, and there is evidence of potentially better long-term outcomes. That's very controversial. But if we can find PCOS early, if we can find endometriosis early, if we can find luteal phase defects early, we can help with prevention of infertility. There are women that I've treated before they got married and decided to have a family. I had one patient get pregnant on her honeymoon after she had endometriosis excision as a teenager.
Huh.
I don't know if she ever would have infertility.
Yeah.
It's a beautiful thing. I don't want her to ever go through that, right? We could prevent infertility with proper understanding of the female menstrual cycle.
Yeah. Well, I certainly agree that it would bring so much more awareness early, which is important in any of these sort of conditions, right? Is the early.
But for the 29-year-old, okay, so she didn't get to go to that class at 13. Do it now.
Yeah.
The one thing that everyone says, including me, when I learned this on the side, not in med school, you learn more about the menstrual cycle than I did in med school at these sessions. Me and everyone else who takes this class says, why didn't I learn this earlier?
Yeah.
This is data I deserve to know about my own body. When am I fertile? When am I releasing an egg?
Yeah. And I mean, from what I understand, releasing an egg, although apparently the medical literature is the opposite, but yes, releasing an egg is helpful for health and longevity, right? Yes. So can you walk us through that? Because, I think there's some women having, inovulatory cycles, some women with PCOS who are not ovulating. And why do you kind of see it as, a biomarker in and of itself?
There's so much data showing that bioidentical hormones are a promoter of health for women. And then there's male literature supporting that too, right? But they're different. And women are the ones that we just seem to not understand, right? So the most important thing first to start off with that there's misinformation about is that there are bioidentical hormones, identical to what your body makes, or there's so many different names for them, but body identical, natural, versus synthetic, like what's in birth control. Yeah. So they're very different. One works, the synthetic ones tend to be used in a way to suppress or shut down your own hormones, override the brain, and replace it with these synthetic hormones. And in some ways, they can be better for cancer, for example, where we have to have really high dose progestin, which is the synthetic version of progesterone, act at a certain site, targeted site, like the lining of the uterus. Yeah. So that can be really good for things like cancer, okay, once you have it, or pre-cancer. we've seen that, which women with PCOS are at increased risk of.
Yeah.
Why is that? Because their hormones, they tend to have too little progesterone. And if you have progesterone, you need to have natural cyclical progesterone to let your lining grow and shed in a healthy way.
Yeah.
And if you don't have that, which is often the case with PCOS, you can have that lining get confused and turn into cancer. So that natural rhythm of the body is so important. And it's mainly the luteal phase is the key. The key in the luteal phase is progesterone. Progesterone stabilizes the lining, prepares it for pregnancy, and changes that to anti-inflammatory hormone, anti-cancer as well. It has anti-cancer properties, or it even has tumor suppressor genes. It will also change cell types from proliferative to secretory. So it changes cell types and stabilizes them. That's the whole design of progesterone.
Interesting.
And it's an unsung hero. It's typically, or it should be, much higher than estrogen actually in the luteal phase. Consider estrogen as a house, and progesterone should be a skyscraper in the luteal phase. That's how important progesterone is, and I doubt you hear much about it.
Yeah. And how long should that is 14 days, 10 to 14 days? What's normal for a luteal phase?
Yeah, it should be consistent from cycle to cycle and should be, around 12 to 14 days.
Okay.
Yeah.
So if you're listening to this and you are having, obviously, we'll link the Creighton method, which I think sounds amazing.
So less than 9 days is a major red flag, and premenstrual spotting is a red flag as well. So if you have 3 days or more of premenstrual spotting, that's a sign of a luteal phase defect.
Yeah.
If it's less than 10 days, that would be something that would be concerning for me. So I would say less than 10 days, major variation of greater than 3 days from luteal phase to luteal phase. That's where the 3 days gets in. And a lot of premenstrual spotting. Those are all signs. Or not having any luteal phase, for example, that can happen too.
Yeah. Well, some people obviously have short luteal phases. What about individuals that are having longer than normal cycles? What might that be indicative?
So that is, it could be a few things, right? Because I'd have to look at the biomarker data to be able to tell you. Typically, the follicular phase is variable, and the luteal phase should be stable. So if you have that, that might be pretty good, even for a woman with PCOS. If she's ovulating late on cycle day 20 and she's having a healthy luteal phase and her cycles are 32 days, that's fine. And I'm okay with that. I'll work cooperatively with her body to help her conceive if that's her wish, for example, as long as the cycles are less than 35 days. It's typically normal. So the follicular phase is variable. So different things can change the follicular phase length. Even stress, for example, can delay ovulation. That's a adaptive mechanism likely. You can even have a split peak, for example, under stress. That's one thing we see, where the body will start to shoot up estrogen, which then causes the mucus to release, and then it might stop, and then it might happen again. We see a sputtering effect under stress typically, and that can delay or prolong the follicular phase. So that's fine, especially if it happens as a one-off, right? Oh, I had my wedding. That's common. And that's another reason why just not understanding the big picture is a problem. If you're just doing calendar method or some non-cervical mucus method, you're going to miss those nuances that are going to show up based on your life. And you're really going to understand your body in depth. I've been doing this for cycle charting for, I think, 15 years. I have 15 years of biomarker data on myself, for example.
Yeah.
And I can look back, where are my cycles now? What were they like before? But yeah, the key is stability of the luteal phase that you want to see.
Because if the luteal phase begins to shorten, what can that be indicative of?
There's ASRM, the major IVF organization. They acknowledge that there's likely existence of luteal phase defects, but we don't know how to diagnose them. We don't know how to treat them. We don't really know what they do. We think they're correlated with miscarriage, but really it's way more than that. They're associated with PMS. I suspect breast cancer as well. I suspect other types of cancers, because that beautiful ebb and flow of the hormones that the cells in the body are designed to go with. So the breast tissue are cycling just like the lining of your uterus is.
Yeah.
And so if there's an abrupt drop of that progesterone, that anti-cancer, anti-inflammatory hormone, those cells are not going to know what to do. And imagine if that happens over and over and over. Eventually, one cell is going to go rogue.
Yeah, that makes sense.
And so I believe luteal phase defect, likely we don't have really data on this, right? Because no one's even acknowledges that there's a luteal phase defect. So I can't even tell you that there's data to predict cancer, but it's very likely. It makes sense, right? When you really understand the female body, that there's cellular changes mimicking the lining of the uterus, but women are more than their uteruses, right? Like that's one thing that we forget with medicine, and how as doctors are trained, it's like, this is my organ is the uterus. No, my patient is more than her uterus. She's her breast, she's her bones, she's her brain. And so we see those abrupt progesterone drops, luteal phase defects cause PMS, because the GABA receptors in the brain, which are the same receptors that Xanax binds, are impacted. So progesterone has anti-anxiety medication impacts on the brain, because it binds to GABA receptors in the brain and calms the brain with anti-inflammatory effect.
Yeah, that's I was gonna ask more about PMS, but I think you kind of just, put it in a nice short little answer, because so I've never had PMS outside of when I had to take antibiotics for this explant that I did, and it wrecked my gut. I mean, I knew that my gut was really like wiped out. And I saw my beta-glucuronidase increase quite a bit, which is a kind of marker of estrogen in the gut, I guess is like a simple way to say it. When it was clear that my hormones were negatively impacted and they were no longer like in this proper cycle because of apparently what had happened. I mean, the gut, would you agree that the gut and hormones are pretty tightly connected?
Absolutely.
Okay, so it was just wild because I test so much. I have all this like obscure like data that I can put together. So did the antibiotics, the gut was like wiped out or impaired, which then my beta-glucuronidase increased. And that was the first time ever for like 2 or 3 cycles that I ever experienced PMS symptoms.
Makes sense.
So it's wild, right? So, I mean, would you say then just by having PMS symptoms, does that mean someone's not an optimal, or is there anything that you can do about that?
Yeah.
Okay.
Yeah. I mean, PMS is a legitimate medical condition. It's not just women being women. That's not a thing.
Yeah.
I don't believe that. That's a bias against women because we don't have enough research on it.
So where would you start? Like if you are experiencing PMS symptoms?
Cycle charting.
I know. Okay, well, yes, the cycle charting. Okay, then,
but
we'll assume it all things.
Okay,
First, cycle charting.
Okay, so we want to identify when do they ovulate, right?
Okay.
Then we can, and I need the cycle chart to be able to teach her. Okay, so we call that peak day, the last day of cervical mucus, and it should be the most fertile mucus.
And how many days is the cervical mucus?
A healthy window, I would say, is around 5 days of cervical mucus.
Okay.
A lot of my women with infertility have cervical mucus issues, so they may just have 1 day. And as long as they know that 1 day, it helps them.
And is it
time intercourse?
Is it kind of like is it lighter and then increasing? I mean, this is just off personal experience, but is that what it's supposed to be?
So peak fertility mucus is clear, stretchy, and lubricative. You want it to be clear, stretch more than an inch, and have that lubricative sensation.
Okay.
It starts tacky and white or gummy and then it will change and have so it increases it has channels in it. So peak fertility has special channels to help filter the sperm to get to the destination. Also nourishes sperm.
Oh, interesting. Man, the body's so amazing, right?
Amazing.
Of course it does.
Okay, this is peak day. I want you to go on peak plus 3, 5, 7, 9, 11 for estrogen and progesterone blood draws. And I want to watch that rise and fall. And with some women, they may not get that far throughout because it's short.
Yeah. And then as it relates back to the PMS, so what do they do then? Like, what are options here?
So, it really depends on what you want, right? So if you're going to someone like me, my tools are, I will prescribe the bioidentical hormones for you. I will see, okay, when does your estrogen drop, or is your estrogen okay? Or does your progesterone drop? And then I can do targeted hormone support, cooperative cyclical hormone replacement therapy, essentially, for young women that are cycling, and it helps tremendously. So the menopausal influencers and, they get it. They understand that that's amazing. That's swept the internet, but this has not yet.
Yeah.
That this is a possibility. Because if you don't know when a woman ovulates, how would you be able to time it?
Yeah, of course. Okay, would this be like a bridge, or would this be something that the woman would be expected to be on for an extended period of time?
It really depends on the case, right? And what the patient desires. So are there women that are like, I really want to go deeper and I want to go to a naturopath and I really want to understand, do I have nutrient deficiencies? By all means, we could keep you on that while you go do that. Or is it a PCOS patient and she doesn't really cycle? She doesn't even ovulate. So I force a luteal phase in that case, in a sense. I trick the body that it ovulated and I induce a period, and that will reduce testosterone and reset the brain like a computer, because it's frozen. PCOS can be a frozen state of the ovaries. That connection between the brain and ovaries. So I can target progesterone in that population, for example. So it just depends. But I would say a lot of my patients are happy with it, and especially if usually it's progesterone is the most common one. And it has such a wonderful side effect profile for most people. Obviously, it's different, depends on how they respond. But when you take it, for example, orally at night, it gives you wonderful sleep. Yeah. So a lot of women enjoy it, and it just gives them so much, just such a better quality of life, and they respond so well. They can predict their period even. Their cycles are more regular. They're sleeping better. They feel better. Their mood may be better, depending on what it is. There's even data that shows a small amount of women that did have targeted cyclical progesterone, bioidentical progesterone, and it treated seizure disorders that were PMS in the PMS period. So there is some published data on that, and it just depends on the case and what they need it for.
Got it. Yeah, that makes a lot of sense. I mean, I think that this is something that we're not talking about nearly enough, but it's super helpful. I mean, the investigator that I am, I would probably want to get to the root cause and optimize that. But I think I just call it a bridge, but, as a bridge until you were able to resolve that, if possible, I think it's a really incredible option for women. And I guess if you're not interested in, doing everything or looking for the root cause, then this is also great to prioritize your health still. And obviously it has fertility, pregnancy implications too. So I love that.
And mind you, I get a lot of the really hard cases too.
Yeah.
Right? So
that makes a lot
they
of sense.
really, really benefit from progesterone long term sometimes.
Yeah. Okay, you told me something interesting yesterday about reversing this high FSH with DHEA. I think probably we should explain what FSH is, why it might be high, kind of like set the landscape for anyone that doesn't know.
Yeah, so my version of AMH, a fertility test, other than the cycle data itself, is cycle day 3 FSH.
Okay.
And so cycle day 3 FSH is a report card of how the ovaries and the brain are signaling to each other. If I suspect PCOS, I'll do LH and FSH. FSH should be higher than LH at that point in the cycle. If LH is higher, like 2, 3, 4, 5 times, that suggests PCOS, and that computer is frozen because and then their ovulation sticks are all messed up too. But FSH is fascinating because if, let's say, that luteal phase has too low hormones, or she's not really ovulating very much, that FSH will rise because the body is working really hard to ovulate. The brain is sending signals like, hey, wake up, ovary. So it's going to keep going up and up and up to scream at the ovaries. So when you start to hit towards perimenopause, in a sense, FSH will go up, or menopause, FSH is really high because the brain is screaming at the ovaries because it's saying, oh, you're not signaling enough. I'm not reading you. I'm not reading these hormones like I should. So I'm going to send more FSH to wake you up.
What do you look for FSH to be in someone that's not in perimenopause or menopause on day 3?
Less than 10, typically.
Okay.
One could argue, I guess, optimal could be less than 8, but really fertility outcomes, I don't see any difference if it's near 10.
Okay, interesting. Now that we've kind of laid the groundwork of what FSH is, so What is this kind of protocol, like the overview for what you're doing with the DHEA?
Yeah, so FSH has many causes for it being elevated, right? So, but specifically, the easiest way that I see that's very accessible to reverse FSH is if the DHEAS levels are low,
Mm-hmm.
that taking DHEA under monitoring of a healthcare professional can reverse that dramatically.
What's the relationship between these two?
DHEA is a precursor to estradiol and testosterone. So that's why you do want to be careful.
Mm-hmm.
And so I see it as filling up the gas tank.
Okay.
And also DHEA helps with egg quality too. It's an anti-aging hormone.
Mm-hmm.
So there is a version of PCOS where women have high DHEA, but it's kind of not all bad. I mean, you don't want it, but I'm like, hey, there's some benefits to that. Like, that's an anti-aging hormone. It's really high. And high DHEA also helps reduce miscarriage rates. Or having normal DHEA. Too low DHEA will mean that you have likely too low estrogen in pregnancy too. So they have tested that in IVF. There's some small studies showing DHEA supplementation when needed can help reduce miscarriage rates.
Got it. Okay. Well, that's super helpful. You kind of refer to when we were chatting yesterday about more of this like biohacking approach, possibly.
Yeah.
How do you incorporate that into your practice? There's so many things that we could do under the biohacking flag. I mean, I took you around my house. There's there's like a million things. But I also think of like sleep as biohacking too.
Exactly.
And exercise.
Yes.
So what are your like core, like what should every woman be doing for better hormone health?
I think we need to be kind to ourselves.
Yeah.
Right? Like what I see, women are so hard on themselves. They underestimate the severity of their symptoms oftentimes. They're hard on themselves, that they're not doing enough. They're not doing, good enough. They're not setting boundaries. They're people pleasing.
Yeah.
All of those things. And then that leads to poor sleep, not going to bed enough, not going on a walk, not taking care of yourself. So common sense, I think we're losing just the basics of going outside, being in nature, true companionship, not just the internet.
Yeah.
I think those things and that just nervous system security that we need, I think those are the things that we're losing in this culture of intensity. Like there's a lot of wonderful things of technology, AI, all this information at our fingertips, but also we have to unwind as well and be kind to ourselves, because I think it's like the temptation with all the information is, well, I have to be perfect in this way and that way and that. No, we don't. We don't, right?
There's no
perfect
ways. Yeah.
And so we really being honest with ourselves. And I want to do this for me more. Like I want to go on a nature walk to feel better. Like I want to do this biohack because it makes me more energetic so I can enjoy my life.
Yeah.
Not like I have to do this thing, take this supplement, or else my fertility is doomed. Like those are two different mindsets. The mindset is everything when you do this, right? It's how you do it. And I think that's lost in the internet age too, because they're selling you, all these toxic things are in your house and it's going to cause you infertility, right? And that's just not the right mindset. So I think I start with mindset.
Yeah. Yeah, it's so important. I mean, actually, it's an interesting topic for me to maybe share a little bit on because, I think like I just had this reel that I didn't go viral, but it got like, a couple 100,000 views, and it was for an event that I'm speaking at, which is great, but they gave me what they wanted me to talk about, right? So they wanted to focus on a lot of the technology that I have in my house. So individuals that weren't aware of who I am outside of that one reel, right? They're just like, oh, well, health can be so simple. And I'm like, yeah, totally. Like I would never have moved on to any of this stuff if I hadn't already completely like mastered that. But then there's the idea of mindset. Like a few people were like, is she mentally ill? Like this, you have to be mentally ill to want to do or to do this stuff. It sounds miserable. It sounds so unenjoyable. But what you're saying and what I have experienced is true is about mindset, right? Like I literally wake up and I think I'm so grateful and blessed to be able to do these things because, yes, I may be a unique person that enjoys this more than other individuals, but there's not a time where I think of this as like a chore. You know what I mean? It's like I get to. I mean, has there ever been a time where I didn't really feel like working out? Yeah. But did I feel better after I worked out? Was I glad I did it? Yeah. But my mindset is Not that this is all like horrible. I have to do all this stuff. My mindset is truly, like I'm super grateful to do it. And if there's a day that I don't feel like doing something, I don't, you know what I mean? I will pick it up later in the week or not. I have health reserves now, hopefully built up. And I get to do it all with my husband, like he loves this stuff too. So we get a lot of quality time. But I also prioritize rest for sure. So it's something I've gotten a lot better at over the years. I've been an entrepreneur for so long. I used to like fall asleep with my computer way back when. But now my husband has really taught me to shut off. Like when we're done working at like 3:30 when we eat dinner, like we're done for the night.
That's great.
And, we don't have kids yet, so I know that will change. But how you see what you're doing is so incredibly important. So,
and rest is productive.
Yeah, totally.
We
Rest
forget
is
that.
so necessary. Yeah.
Companionship.
And real rest, not like, how are you resting? Like, are you resting by, doom scrolling and evoking anxiety in yourself? Like, I'm not trying to make anyone feel bad, but if you're telling yourself that that's how you relax, but you're not really relaxing, you're actually stressing yourself out more. So you might have to do something that feels boring, but it actually is rest, right? Like reading a book, or for me, praying, or, doing one of these things. That's actually rest. And I know that because on my Oura Ring, which I know you're not as about every little piece of data, but now I can confirm when I scroll on social media, I am not in a restored state. When I read a book or read my Bible or pray or something of that nature, I am in a restored state. If I'm on a nature walk with my husband, I'm in a restored state. If I'm just quote unquote relaxing but stressing about everything I have to do, I'm not in a restored state. So,
yeah, I'm not against the data. It's just like you said, it's the mindset. I'm just worried that people put too much emphasis on this device if they don't understand it, right? Or if you make it control you. That's, are you in control? Is it bringing you peace? Is it bringing you joy? Mm-hmm. Is it what's best for you, essentially?
Yeah, absolutely. And I think, you have to have awareness as well. Like, when may or may not be a time to have a ton of data. So if you're going through an incredibly stressful period or something, then it might be a time to not be looking at data because it's not super helpful at that.
Right. And that's the patient population that tends to come to me is if I do more, it's more likely to work. That's how everything else worked in their lives before. But fertility is different.
Yeah.
More data isn't always better. It doesn't give you more control. In fact, it can lead to that spiral of anxiety.
Yeah, absolutely. Do you look at any other labs that you would deem interesting that maybe aren't spoken about very often?
I think a lot of, overlap with just a lot of the longevity people that I really like insulin resistance testing with insulin levels.
Do you like a HOMA IR or are you just looking at insulin and glucose?
I do a 2-hour glucose test with insulin at 0, 1, 0 and 2 hours, but you could do more in between as well, which could all give you more data. FEM is another branch of restorative medicine. There's different types, FEM, Neo, NAPRO, but FEM has a very intense protocol for insulin, but really I think there's an overemphasis on just fasting insulin. I think it's important to see what the insulin is doing in response to glucose as well, because we miss a lot of people with that.
Yeah, I would agree with that. And then let's say you have high, insulin or fasting, whatever your doctor has checked. What would you recommend starting to do?
Yeah, it depends on the case. Ideally, look at the lifestyle, diet, consider supplements like myoinositol or other things depending on their reproductive goals, or medications depending on the severity. If their blood sugars are starting to be abnormal, that's when we may start to do medication management as well. So it just depends on the case, their goal.
Would this be the hormones or what?
Like metformin even, or another.
Berberine?
Berberine is good. I love berberine, but it's not as clear the safety data for pregnancy. So I tend to go towards myoinositol, which is wonderful in pregnancy as well. There's data to show using it in pregnancy helps with outcomes, reduced preeclampsia, reduced gestational diabetes as well. So myoinositol is my main go-to. And again, I try not to overdo the supplements, but I do really like berberine. I think there's a lot of benefit for berberine.
What about some of these supplements that are kind of viral on the internet for being good fertility supplements? CoQ10.
CoQ10 is great.
So, okay, cohesion, you like.
Just be careful with the price, right?
Yeah. What do you think about the new kind of like or budding research on NMN or NAD precursors and fertility?
Yeah, I mean that's what antioxidant. I use NAC.
I see. Yeah.
NAC. I've used glutathione. I will, for anything that's good for antioxidants will help with egg quality.
Yeah.
So focusing on one of those supplements for egg quality is great. What I like about NAC and glutathione is that it can actually help with cervical mucus as well. So you get double benefit for that. So those are the ones that I've primarily used in my practice.
Anything else like supplement-wise that you like?
And yeah, it just depends on the case. Those are probably my most common ones. Alpha lipoic acid is a really good one. Alpha lipoic acid is mainly used, in my case, if I'm suspicious of inflammatory environment in the uterus. So women who tend to get subchorionic hemorrhages. There's small data to show progesterone plus alpha lipoic acid in pregnancy can help shrink subchorionic hemorrhages.
Can you explain to the audience?
So, sorry, that's like a bruise behind the placenta. And so placental development occurs during that luteal phase. So between ovulation and when you would miss your period. Okay, so the environment of that uterus, including the hormone milieu, the immuno environment, is so important for the ability for that placenta to attach and grow. So it's important to have optimal hormones, but also reduce inflammation. That's why things like premenstrual spotting, tail and brown bleeding, it's like, oh, okay, well, maybe there's something going on there. So if we can optimize placental development, we're going to have less likely problems with the placenta. The placenta is absolutely critical for protecting that baby and helping optimize blood flow, nutrient status, epigenetics, reducing risk of stillbirth, for example. So what we see with some women when they have inflammation in the uterus, or for whatever unknown reasons, because people aren't really studying this, is that we can see bruising behind the placenta, likely due to some kind of immune system disorder, blood clotting disorder, or inflammatory environment, and some compromise between that interface between the placenta and the uterine wall. And most of the time they resolve, but they're definitely a risk factor for miscarriage, or if they get really big, sometimes later losses or preterm birth or premature rupture of membranes. I've seen that as well, because blood is an irritant to that, the chorionic membrane, the sac that surrounds the baby.
Yeah. You sent me something earlier today about the placenta being like a biomarker of health. So would you test the placenta? Is that like, how do you know what your placental health is?
Right. Yeah. Well, so yes. So there is a movement called Measure the Placenta. So women who have had stillbirths that occurred tend to join this group. And there's small data from, it's like one of the big academic centers like Hopkins or something, or maybe it's Harvard. And they've been able to do 3-dimensional measurements of placentas to predict stillbirth before our conventional tests can detect it. Now, it's controversial. I try to bring it up to my institution. They're like, well, that's really hard to do. They didn't think there's enough evidence, or it was hard to actually get done. But there are places doing that. So yes, there are markers. There are other ways to look at the placenta. So the size, was there a growth issue with the baby? Stillbirth would be an issue. And there are ways that they look under a microscope too, that if you get your path report, they may show signs of like infection, for example. So they'll look at all these things if it's abnormal. But another thing would be subchorionic hemorrhages would suggest there's some problem, maybe not with the placenta itself, but the way it attached too. So that's another thing. But so preconception health will help optimize eggs, hormones, and then that 2-week wait time is when I also sent you an article about telomeres in the first 5 days. So before you even know you're pregnant, that embryo turning to a blastocyst is growing telomeres. So these are genetic material at the end of the genes that are predicting longevity of that child are proliferating, and then it stops at 96 hours. So in that first half of the 2-week wait, the telomeres are expanding, and in the second half, the placenta is attaching and getting its nutrient status established, essentially. So if you optimize that 2-week wait of hormones and nutrients, especially by prepping the 3 months before, you're going to have a better foundation for pregnancy, right?
Yeah.
So with a healthier placenta, you're likely to have higher, robust progesterone estrogen pregnancy. And I can tell you that I've done it myself with different pregnancies, and I've watched my hormones respond in pregnancy to better hormones in the 2-week wait time.
So do you only have this 2-week period, and that sets like the tone for the whole pregnancy, or can you impact that?
That's the most impactful,
from
what I've seen.
Okay, got it.
So it kind of, I would say that if you had to really, that's what you're really prepping for. Those 3 months preconception, you're prepping for that implantation time.
Yeah.
In that preconception period, your health in that whole window is going to predict the health of the pregnancy.
Got it.
Right? So like if you have hypertension before you, in that 2-3 months ahead of time, you're more likely to have hypertension and preeclampsia. If you have insulin resistance, again, diabetes, hypertension, preeclampsia.
Yeah.
So whatever you can do to optimize your preconception health is going to pay off during the pregnancy, which impacts the health of the baby, which is a window into your life in 40 years or 20 years. Women who have gestational diabetes are at 50% increased risk of getting type 2 diabetes later in life. Now, does that mean you're doomed for it? No. I'm like, I tell women all the time that have this in pregnancy, don't see this as a doom thing. No, this is an opportunity. You saw a window into your future. You are on the track of becoming a diabetic.
Yeah, that's
But
important.
let's be more motivated now to focus on protein, maybe myoinositol for life, more activity, walk for 10 minutes after your meals. Maybe do a continuous glucose meter. See what meals aren't working for you. See where your body isn't happy.
Yeah.
Maybe you're going to feel a lot better. Maybe this is just an opportunity. So how do you frame your mindset? This is an opportunity.
Yeah, I love that. Yeah, I think all of this under the right lens is an opportunity, right? Because something dysfunctional, especially, like I'm super in tune with my body. So if kind of anything starts to shift, I feel like I'm made aware of it really quick because I'm also, but I am grateful for that because I'm like, okay, well, let's dial back in if something is feeling to be going in the wrong direction. But I think it's become so normalized to feel awful that we're missing those signals as women.
Yeah, we see it as a weakness, right? We see our symptoms as a problem. But no, again, they're an opportunity. Your body is wise and it's telling you something's wrong.
Right.
We really should be in tune with it and listening to it. That's inherently when you chart your cycles or do an Oura ring or whatever, you're starting to go back to that. But that's also why I really like you really understanding what the biomarkers mean, because you're really becoming into turning in.
Yeah.
To what is my body telling me with this data? Not what is this app telling me? What is my body telling me?
Yeah.
And what do I need to change?
Yeah, absolutely. Okay, so curious. I mean, an area that I'm really interested in is this ovarian longevity, right? So obviously, if we can extend the fertile years, again, I'm still I can't get over the fact that the medical system says that ovulating is the bad thing. Because in my mind, I'm always like, how can we ovulate for longer? Is what I'm thinking.
Yeah, and that's what the literature does show, right?
Right. If you're able to augment the FSH, which, as we know, increases as you get closer to menopause, do you think that could extend ovarian aging or ovarian longevity?
Yeah, absolutely. Yeah. So that's one thing many of my patients want is they want to extend their reproductive lifespan. They're in their 40s and their ovaries are trying to shut down and they're like, I want a baby or I want one more. How can you extend my time? Yeah, that's what we're doing.
And let's say, I mean, we haven't talked too much about like lifestyle, but we will get into that a little bit more. But let's say that lifestyle is all good, right? It's pretty dialed in. sleep is going well, they're exercising, eating a healthy diet. Is that where the intervention of these hormones would come in and you're extending that?
So hormones are absolutely one component of it. So cyclical progesterone support and or estrogen support in the luteal phase helps reduce that FSH and buffer that time. In supporting DHEA are two big ones.
Okay.
And over time, when FSH goes up, there's a desensitization process, receptors turn in. So there's a whole cascade of things that are happening that we can't see on paper or on labs, but the sensitivity of the receptors change too when you support hormones, when FSH is going down, when the progesterone and estrogen ratio are healthy. So it's such a dynamic process that most people don't even think about or don't realize that's happening. But those receptors, when they're desensitized, like FSH, that's when your ovaries also are responding less to the hormones that you have, and it's just kind of a down spiral. So you can bounce back by knowing that this process is happening, just supporting what physiologic levels are, and you'll see a lot of improvement and definitely prolong that. Other things, just really paying attention to the autoimmune nature of things that may be happening at that time in her life, right? Because we see when women are heading into perimenopause, estrogen is really wreaking havoc, the immune system's going crazy, autoimmune diseases are starting to rise at that point, and breast cancer, there's so much chaos at that time. I think it's because we don't have that stability of progesterone. And so we want to look if they're having a lot of thyroid issues, potentially looking if they have autoimmune thyroid things going on or other autoimmune issues. And there is some thought that ovarian aging is related to some kind of autoimmune process. I think what it really is inflammaging. I'm sure you've heard that term. So inflammation, aging the ovaries. And I think they're very sensitive to that, especially where they're located in the body. And especially if we have other things going on, like endometriosis is going to accelerate that.
Yeah, that makes a lot of sense. So then, I mean, obviously it's going to be so bio-individual, but like if the standard recommendation for starting hormone therapy is like, let's say, what's the average age of menopause? 52?
Yeah.
If it's then, which I suppose, well, first of all, let's be honest, most doctors are still not even recommending hormone replacement therapy in general. I think about 5% of women only are on hormone replacement therapy, which is wild to me.
Wow.
Yeah. So first, let's get over that hurdle. Let's say your doctor does recommend it, and they would probably do so around menopause, right? So
yeah, or if you went into premature menopause less than 40, there are definite clear guidelines around the world for HRT for that population. And they said the birth control pill is not sufficient.
Well, that's good,
right?
That's great.
So there's somewhat thing in between though, right?
Yeah.
Okay, menopause early or menopause later. HRT is especially important when you're 25 and going through menopause, right? There's clear data that mortality rates are increased. You will die younger if you do not get HRT. We know that. But what about the middle ground?
Yeah, exactly.
There's obviously going to be health benefits if you support physiologic levels of hormones in that middle ground. Yeah. But it's radio silent.
Yeah.
No one is talking about that.
So I guess what I'm trying to get at is, when would you start? It's like, was it, okay, let's going back. We're doing the cervical mucus checking again.
Right. So what are the biomarkers? What are the symptoms telling us? Right? So if they're coming to me at 15 with luteal phase defects and PMS, we'll start then.
Okay. Yeah.
And more likely, this population are going to be more complicated. We're talking about typically they have endometriosis and other things going on.
Yeah. Okay.
Not always, but
yeah.
I don't think there is too early, really, because we're working with the body for physiologic levels. I mean, they should be cycling, right? Yeah. Technically, but we do give hormones in really young women for certain medical conditions too. So there are some times, but not for this, right? We're talking about cycling women and it's of course harder in the first 2 years, what's normal and abnormal. But if they're having major life issues like PMS, missing school, very heavy bleeding, pain, if they're considering seeking help, right? We do have options that are other than shutting down the body, which is especially important that first year or two. Laura Bryden is a naturopath, And she has this theory about how your body is learning kind of how to ovulate and get in that rhythm and how important that time is.
Yeah. I just interviewed Laura.
Oh my gosh. She's amazing.
Yeah.
Yeah.
Yeah. I really like her. Okay. So basically anytime that if you're having dysfunction and it's going on, like how many months would you say that it's going on? Because it could be a fluke, right?
Right.
It's
So yeah, one cycle. No.
Okay.
So typically 3s.
Okay.
Women work in 3 months. That's whenever you do a hormone intervention, you want to give it 3 months to work.
Yeah.
To really look at the big picture. Is it helping? Your body adjusts over 3 months, a woman's body. So even post-surgery, your healing takes 3 months. After a change in hormones, it takes your body 3 months to hit its steady state, new steady state, and see how you are adjusted.
Yeah. Because I think I've been told that, and you can tell me if this is true. So something that, let's say you had an incredibly stressful life event or toxic exposures or something of that nature, or you got wrecked 4 months ago. It wouldn't play out in your cycle right away necessarily, right? Can it take time to actually have the dysfunction because those follicles were already developing?
Yeah, that's a good question. I mean, you would have to have research on that.
Yeah.
It's much easier to make the association. Oh, I had my wedding and my peak day moved later. So I would say that's typically what we associate. But it would make sense. Technically, in 3 months, our bodies work in 3-month windows, which makes sense, right? The whole follicle is being recruited during that month,
Right.
during those 3 months. So, I mean, that's absolutely plausible.
Yeah. Okay. Interesting. When you, just to go back to define a term, you said physiological levels. Can you define that for our audience?
Yeah. So physiology is the way your body is supposed to work. So physiologic levels are optimal levels, target levels of hormones. So they're reaching where they should go at that time in the cycle. So we have very little data on that. It's based on Dr. Hildreth, who I trained under in my fellowship at Creighton. And he had a small sample size of women that had no issues, perfect biomarkers, no miscarriages, no infertility, no PMS. And he plotted their luteal phase hormones based on the cycle chart data. And we used that. And it's worked tremendously well.
And what does that data say? Like, let's say 3 days post-ovulation in luteal phase, where should progesterone be-ish?
Well, gosh. I mainly remember peak +7, where it peaks. Estradiol, you see 120, and progesterone 16.
Okay.
And so, plus or minus, right? It doesn't have to be perfect, but it's around that ratio is the most important, I would say, more so than the absolute values.
Okay.
But both are important. You have to see the clinical context and everything. Was it a fluke cycle? So it's more than just, it has to hit this target exactly, right?
Yeah. So when you're prescribing progesterone in that luteal cycle, you're aiming for about 16. You're not aiming for what would be defined as super physiological doses that some people do in like hormone replacement therapy, like for menopause.
Right. And no, exactly. No. So of course it would depend on the case.
Yeah.
Usually not.
Yeah. Because sometimes, I mean, I don't know if this is how you're supposed to do it or not, but you know, some women during menopause, when they're on HRT, they will feel better at higher levels than your body would have naturally been making.
So yeah, that goes into there's 2 different schools of thought, at least in HRT world, especially menopause. There's a lot of talk and it's fascinating. Should we be basing it off symptoms or off labs?
Yeah.
And then if labs, then what? To me, it makes sense. You should base it off objective data like labs. And what is peak fertility technically? Age 25. To me, someone around 25, peak hormones, like we should be using a woman with good biomarker data without those symptoms and having a lot of women and doing their hormone profile and optimizing it based off that, even at 60, if you choose after the risk benefits, deciding for HRT.
Yeah, because that's like another area in which some women, I think, kind of run into a roadblock, right? Because like my own mom, for example, she's 53 and, you know, she went into menopause a little early, about 47. So when she went to speak with her doctor about getting on HRT, I, was explaining all the benefits to her. And she's like, well, first of all, he doesn't want to put me on it because he says it causes cancer. And
so that's because of the DHEA study, which had extreme fundamental flaws. And what did that do? It set us back decades.
Yeah.
And women's and
It's wild that like how much that got press. Why can't we get that much press for the disproving of that study?
Because it's not sexy.
Yeah, I guess.
And you know, it's like, is it going to make money? Is it going to get you attention? I mean,
yeah,
restoring health, it's a little harder to sell.
yeah, yeah, that's true. But then the second step is, let's say your doctor is even open to putting you on HRT. Number one, they might have not been trained on, you know, the dosing.
We absolutely were not trained.
Yeah.
I had no idea there was a difference between synthetic and bioidentical. I didn't know that if I was giving synthetic to cycle a patient for in PCOS in my clinic, in training, that I could cause birth defects.
Wow.
To induce a period in a PCOS patient who was potentially using days of fertility.
Yeah.
And that's when I was like, oh my gosh, this is a huge problem. I didn't know there's a bioidentical and synthetic. And I had to teach myself and figure that out before I did my fellowship. But
yeah. So yeah, it's important.
So it's kind of scary how little we are taught in our training. We have to figure it out. We really need to seek out this information.
Yeah, I mean, and you would think, like, you know, even training like as an OBGYN or anything with women's health, like you would think you would get more training around that.
Yeah, I mean, you know, our training is mainly to keep people alive. Yeah, as doctors, you know, we are there to protect people's lives. So
yeah,
doing emergency C-sections and that's why I'm talking about the importance of subspecialties, right? Because women do deserve more than just life and death. Quality of life matters, and that's why we have these niche people coming off and doing HRT, because that's the only way to really do it. It's and our current model does not sustain that. So
yeah,
you have to see so many patients a day if you work at just a standard, you know, medical center.
Yeah,
they're going to make you, or your schedule is just going to be filled with so many. You get 15-minute visits. Lucky if you get 30. And how are you really supposed to understand what their needs are? Talk to them about what's optimal, what the research says, side effect profile, and then read studies on the side and get yourself up to date to be able to give that.
Yeah.
So the model is not designed for that. The model is, you get this pill or you don't.
Yeah.
You know, are you going to die from this or not?
Yeah. I'm excited because there's this. Have you seen Open Evidence, the AI platform?
No.
So it's for providers only. And they already have a integration with Mayo Clinic.
Okay.
So it's I think it should be really cool. I mean, of course, there could be room for error, but number one, the whole charting process in general, like, you know, we were using this so at my clinic, the providers would just have a regular conversation with the patient. And obviously this was functional medicine. So the first visit was like 2 hours long. But it wasn't dictation, but it was ambiently listening to the conversation. It would do the whole chart note for you. So then Open Evidence could be put into that, and it could pull all of the most up-to-date evidence on whatever that specific condition is for that specific person. So I am excited about that possibility. Because it could be really cool, right?
It could be, absolutely.
Yeah, so that's exciting. Okay, well, let's talk about anything else fertility before we move on to endometriosis. So other things what nutritional, you know, recommendations. Nutrition can be so complicated. What diet do you think is best for women that want to get pregnant or improve fertility? Any other?
Depends on what's going on, right? So if it's PCOS, depending on if they're insulin resistant, you know, they may benefit more from intermittent fasting, but some may do terribly on intermittent fasting. It depends on what works and what their labs, what their continuous glucose meter is saying, or whatever feedback that we are using that works with her.
Well, let's run through a couple of like archetypes maybe.
Okay.
So 1, normal, seemingly healthy cycling, cervical mucus is in a good place. General nutritional advice that you would give.
Yeah, I mean, whole foods, high protein, Mediterranean-esque, even though that's difficult to define.
Yeah, that's what I do. Okay. And then PCOS archetype.
Yeah, so not skipping breakfast, high protein, you know, being really understanding of yourself, that there's an adjustment phase and that cravings and binging and mood disorders, all that go with PCOS, and how you have to have compassion with yourself and really realize what metabolic issues are going on.
Mm-hmm.
When you understand that you're having blood sugar crashes, and as you're adjusting and having more protein and exercising and just being kind to yourself. I think women with PCOS are really hard on themselves. They've had such a hard time with easy weight gain or low energy that they blame themselves too, especially because if the medical model isn't really giving them an explanation, they blame themselves. So I think it's just they need to really be kind to themselves typically with PCOS. So I think that first, that's why it's so individualized to talk to the person, and really just getting that data from a food journal, potentially even the continuous glucose monitor for a couple weeks, and seeing how you feel, and just slowly seeing those changes, and not doing it for any other reason except you want to feel better. Right? Not weight loss. Don't watch the scale. But this is for you to have better quality of life. So that's kind of how we work together to potentially take it slow, take it day by day, and see this work in your individual case at the speed that you're comfortable with. Because typically with PCOS, they get really frustrated and then they do an extreme diet and they get disappointed. It's a big yo-yo. It's a huge emotional roller coaster. It's a very difficult condition to live with unless you understand it and you biohack it basically, and understand your labs and what they're saying and the simple things that you can do day to day to slowly reverse that impact.
And can people, I want to make sure I'm using somewhat the right terminology, like reverse it or, stop the symptoms of PCOS?
I think our goal for PCOS and endometriosis should be remission.
Yeah.
I think we should be treating it like that. No, we don't have cures, but that doesn't mean we can't try to put it in remission. And I have seen that happen. Absolutely.
And to my understanding, there's multiple different forms of PCOS, right? So you would be having a potentially different plan for each one of those types?
Yeah,
or
every person is different with PCOS, technically. Yeah. And there are attempts at making subtypes. I learned that from 8 Steps to Reverse Your PCOS by Dr. Fiona McCullough. I really like her. We've become friends thanks to social media. She's great.
I love that.
And she was the first one to show that there were subtypes potentially. Now, we have very minimal data on subtypes of PCOS, but you really should be thinking that, well, this PCOS patient is not going to be like this other PCOS patient. You cannot lump them all together. It's a huge, and I don't like basing it off like weight or whatever. I don't like that. I like looking at the individual. Are they insulin resistant, for example? Is it a DHEA type? Like, is it adrenal? Do they have high androgens on labs? Yeah.
So those are the 4 types, right? So the would you say metabolic? Can you walk us through the 4 types?
I kind of have my own too, in a way. To me, adrenal is its own thing. That's when you have really high DHEA. Yes. And then you have the ones that are really severe. Well, LH is off the charts. Androgens, like testosterone's off the charts. Okay, they're very sick. They typically have insulin resistance. I would say those are the 2 extremes, subtypes that I typically see. And then you have people in between that.
Got it. When you say really high DHES, what would that be?
Over 300, I believe. The labs typically do turn red for that, usually when they're red. Yeah. And then the problem with DHES is that it is supposed to reduce with age. So it also depends on the age of the patient. So, but yeah, typically that one will be red if it's really high.
Got it. Okay.
But they're all so different, but I don't like just saying, oh, they're insulin resistant or they're not. It's typically 2 major subtypes of insulin resistant or not, but with the androgen. And do they have androgen issues mainly from the ovaries, or is it mainly from the adrenals? Mainly, I do those 2. And then there's this big spectrum of the insulin resistant type, high testosterone type. And do they respond well to simple things like cyclical progesterone, helps reduce androgens, lifestyle, reducing insulin, reduces androgens. Are they cycling in response to that, or do they need to escalate to more aggressive measures? metformin, or even surgery.
Mm.
I have surgeries for PCOS.
Interesting. What surgery is for PCOS?
So there are two ways to do surgery for PCOS, and they both work similarly. They're just different techniques. So one is the ovarian wedge resection, where you take a wedge out of this enlarged ovary and make it smaller and more normal size, actually.
Is the ovary getting much larger because there's so many follicles in it, or,
It definitely has extra follicles. So the ovary itself with polycystic ovarian syndrome, it's enlarged and swollen looking with extra follicles.
Got it.
So they are arrested in development. They're just kind of sitting there. And then, so they're enlarged with a smooth surface. It should look like a brain and be crinkly and really large dilated blood vessels.
Okay.
And so what I do is I cut a wedge out and sew it back together to make it a normal size and function more normally. And that resets that whole axis when the computer is completely frozen.
Got it. Okay.
I typically reserve that for patients who have failed lifestyle and medical treatments, and their androgens, like their testosterone, is really high, like through the roof. It's definitely red on the even the standard lab markers. And what I typically see, 60 to 70% reduction in androgens within that 3-month post-op window.
Wow.
Phenomenal results. The studies show somewhere between up to 90% just regularity of their cycles. Go back to resuming regular cycles. Very high fertility rates. That is the closest thing to a cure to PCOS. You really put them in remission for the most part.
Yeah.
Now, do they always have other things? Or many of them, because they're more severe cases, we may still do some cooperative progesterone support cyclically. Some of them conceive spontaneously. Some of them may need some low-dose ovulation meds. Some still may need high if they weren't responding at all before, but that's pretty rare.
And the ovulation or the fertility meds or ovulation meds is inducing ovulation.
Right.
Like in a predictable way.
Yes. Yeah. Working, usually low dose, very targeted to that individual.
What do you typically use?
So first line for PCOS is letrozole. But we do pretty low doses.
Do you ever use like Clomid? Are your friends and I
don't like Clomid too much. It's overused. It's the oldest. It's the only FDA approved one. It's the one we all were taught.
Yeah.
But it reduces cervical mucus the most, has the highest side effect profile, and can thin the lining of the uterus the most. So it's not my favorite. I also sometimes use tamoxifen as well, which is also off-label.
Yeah.
But
have you found yourself exploring any peptides for any of this?
I have not.
Yeah. That might be an interesting discussion.
Absolutely. I'm open always to learning.
I mean, I'm a big fan of peptides for a lot of other mechanisms. I think there could be some mechanisms as it relates to like female ovarian health. But I mean, other goals that you may have, like, I mean, MOTS-C can be, I've seen it, in my previous clinical practice being great for people with, blood sugar and insulin issues. So that's kind of nice. There's some exciting, we'll have a chat about that at some point.
And the other surgery is ovarian drilling.
Okay. So tell me about that.
They put holes in the ovaries, and it probably worked. It doesn't change the size, so it's harder for me to understand. We don't really know how many holes they need to drill. And it does a similar thing. It's easier to do surgically. It's quicker. But the way that I do the ovarian wedge resection, I cut the wedge out and I sew the edges of the ovary together, and it's a smooth surface, so I can reduce the risk of scar tissue. So this procedure was done in the 1930s when PCOS was discovered by Stein-Leventhal. It used to be called Stein-Leventhal syndrome. And they took biopsies of ovaries. And these women would conceive, but later on they were found to have a lot of scar tissue and have fertility issues later, because once you form scar tissue, that's a big problem for fertility.
Yeah.
So it fell out of favor because the old techniques of the 1930s are not what we have today.
Yeah.
Right. And so the IVF doctor I trained under, he brought up that procedure. He said it's terrible, causes all this scar tissue. It's just a horrible procedure. I'm like, we're not in the 1930s anymore. We have modern robotic surgery, for example, that's minimally invasive, that we can make these ovaries absolutely beautiful. And yes, there's always a risk, but this is an absolutely amazing option that doctors aren't even being trained to do anymore, unfortunately.
Yeah. And so obviously out of those two options, you would suggest the one that you're actually
I do the wedge.
Yeah.
I've definitely seen benefit from drilling. I think most doctors would be more comfortable with drilling. Just it's technically easier to learn. And there's actually ways to do it through ultrasound. I saw in some literature, but I mean, honestly, there's risk benefit for everything. And I'd be surprised if you find a doctor that even knows how to do drilling. I hope more learn in the future, because it's just, again, it's so restorative, and it's reusable for future pregnancies, and it will promote lifelong health, and it'll promote health of the babies, because if a female fetus is exposed to high testosterone in utero, she's going to have most likely an increased risk of PCOS herself, right?
Yeah.
And then that's going to increase her risk of cardiovascular issues later.
Yeah, that's a great point. You do PRP injections, like ovarian PRP injections. Where is the use case for that?
Yeah, so PRP is experimental. This technology, like most technology in gyne surgery, I think, is stolen from ortho surgery. So ortho surgery reimburses a lot better than gyne, so they tend to do a lot of innovation. So platelet-rich plasma is similar to stem cells that comes from your own body, from your own blood. So we get a good amount of blood from you, spin it down, and get the platelet-rich plasma layer. And that acts similar to stem cells, where we can inject that and rejuvenate a certain part of the body. It's being used in spas all over for facials and other things. But some people started to do that and inject into the ovaries. And the case reports that caught my eye initially were women that were going into menopause, or sputtering into menopause. And they're like, oh, I really want to try to conceive. And they got this PRP and were able to conceive naturally. And so IVF clinics are using it sometimes to try to enhance their success rates and to promote them and themselves. And but I thought, wow, the risk is low. It's your own blood. It's experimental. As long as I'm upfront with my patients, I love innovation, and it makes sense to me that it could work. And these case reports were compelling, and now more and more data is coming out for it, and it's expensive in a lot of places just because it's so innovative. Some clinics are able to use ultrasound guidance, and they can inject it. I do it at the time of surgery. So I only do it if I'm already doing something else and there's some benefit for them potentially, as long as they understand it's experimental. I'm more likely to bring it up with the patient if their FSH is higher and they're older, for example, or maybe if I'm worried about some other damage or inflammaging of their ovaries of some sort, I'm more likely to bring it up. But again, I'm very upfront. We do think it seems to last somewhere between 3 to 6 months in peak impact. But it's definitely up and coming, and we don't know. It seems to appear as well that when you do repeat doses, for example, in the uterus, they'll do uterine lavage as well, or I've done injection as well into the lining of the uterus. Multiple doses will have better benefit. So protocols are very preliminary. That's another problem. People are using kind of their own protocols, and how you activate it and how much you give and how frequent and the benefits. And there's a doctor using this for PCOS as well. So we don't really know when, where, how to do it, really. There are protocols I try to copy to keep it as standard as possible. And I've seen it's interesting results. I did have someone recently conceive after she had severe inflammation in her uterus. I actually decided to inject it inside the lining of her uterus because it's so severe. Her and her husband were passing back severe infection, chronic infection from something that he had from birth. And this was their second baby, and it was harder to clear this time. We had done this, cleared the infection the first time, figured out it was him that kept giving it to her, which is very unusual. But so they were able to conceive the first time. It was harder the second time. The infection was more difficult to treat, so we added PRP because we were going to go check everything out anyway, and they conceived shortly thereafter. So there's a lot of potential benefit to kind of boost the body's inherent healing abilities, right? To help improve blood flow and whatever these stem cell type factors to reverse the aging process in the ovaries. So I hope more people are able to put this data in a database and really understand, parse out who benefits when. We don't know. The answer is we really don't know. It's very new. But what I love about it is that it's low risk of harm other than the cost and invasiveness of it. You know, if you're doing it transvaginally with the ultrasound, that makes me a little more nervous. That's just not my comfort zone. But if I'm in there for surgery anyway, especially if I'm already removing a cyst, for example, like an endometrioma, a big ball of endometriosis, it's nice. I've already made an incision into the ovary. I might just go through the incision I already made and just give them a little boost of healing. Some people use it for adhesion prevention as well. So there's a lot of potential uses for it. I'm excited that one day I think we'll get great protocols. We just don't know when, who, or how exactly yet.
Yeah, I'm excited about that too. Actually, in the future, I mean, I had my own stem cells banked. So I had some like fat removed and then just a small amount. And then I have them banked. So they're being like cultured right now. So I'll be able to use them for whatever I want in the future.
It's interesting. Is there data on doing that to ovaries, using that kind of stem cells?
Mostly what I've seen is with the PRP, but I also just know because stem cells are so difficult here in the U.S. So there's such a narrow window in which you're allowed to use them.
Oh, really? Okay.
Yeah. So the way I did it is really the only way you're allowed to legally do it, which is taking your own stem cells, having them harvested, and then, you know, you're able to culture them and expand them, and then you can use them. So I'll reach out. I mean, because it's definitely, if it's not already like a major thing, I think it will be in the future. So I am going to reach out to the company and just, obviously I don't need the protocols right now, but in the future, I want to see like how long I can extend.
I mean, you always also have to worry about any weigh the risk benefit of putting needles into the ovaries, right?
Of course.
Right. So the smallest needle as possible. And I try to only go through holes that I've already needed to make for surgery if possible. Or there are ways that I get a really, really tiny needle called a scleral needle. It's really awesome to use in gyne surgery. I just found this out for any surgeons, but really, really tiny, because any raw area on the ovary could scar. Any bleeding could lead to scarring, and ovaries really like to scar.
I was going to ask you, like, how durable are they?
No, they like to scar.
Yeah.
Any injury or raw area on the uterus or the ovaries, they like to scar.
Yeah.
So like when endometriomas, any ovarian cyst rupture, it's concerning when I hear that in a history.
Because it'll scar.
Very likely to scar,
Yeah, that's a bummer. So yeah, we'll see what happens with all of that, but I'm excited to see where the future.
Hey, it's nice. I mean, that's great to have things things like that. Just
I mean, even if I don't use it for that purpose, which obviously, like, if it's safe and makes sense, I would do it. But also, I can just get them back. I'm going to start getting them back IV, like, you know, at some point in the future. So just intravenously. But I feel way better about the risk profile for that because it is your own stem cells. You know,
it's always safer when it's from your own body.
Yeah, I have. Have you heard about V cells?
No.
Very small embryonic-like stem cells. So I did do that once. So there's a doctor, his name's Dr. Todd Ovakaitis, a really interesting guy. And he, you know, helped to figure out this protocol for these very small embryonic-like stem cells, as he calls them. So essentially, the procedure is just the same as spinning a PRP or a PRF. So it's drawn from your own blood, from the platelets. But there's a way to apparently activate these very small embryonic-like stem cells that are apparently living in our platelets. So you can activate them with a certain laser technology. I'll send you some info on it. I find it interesting. So I did do, this was years ago. This is like, I don't know how many years into my clinic. So, you know, obviously I got to explore all these fun technologies all the time because everyone was just coming to me with these great new things. But I did do, so once you draw the V cells, you spin it, you activate it, all that stuff, you put it back in the body just with a little push, but then you can laser guide it. So he showed me these examples of where the laser had been, the stem cells literally lined up. Like they went from being incredibly chaotic in the petri dish to like lining up where the laser had been. So he guided the laser to my ovaries. So, but back then, I mean, I didn't have a biomarker that I could like do before and after.
Interesting.
But for me, it was like, this is super low risk, right? Like it's a red light that I would put on my ovaries anyway. And it's just my PRP going back into my body. So, but that I love this idea. If there is a lot of science behind it, because if you can use a laser to guide those stem cells instead of having to make an injection,
That'd be amazing.
then that would be amazing, right? So, well, I'll send you the info on it.
Yeah.
You have to let me know. Maybe that'll be part of your new practice. Who knows? Okay, so let's go into anything else that you want to touch on regarding fertility optimization, regenerative fertility, etc.
Well, I think systemically, we kind of have to acknowledge that there's a problem when we have more fertility clinics than we ever have had before, but yet our fertility rates are really plummeting.
Yeah. Yeah. I mean, I think I have mixed feelings on it, because as like a person striving to be in the most optimal health ever, yeah, I want like my own natural cycle optimized, etc. So yeah, I mean, this is a great point, right? Like, but the fertility, it's like, what comes first, right? Are people struggling with infertility? The way I see it is because of our lifestyles and current like environments, right? Which is then leading to these fertility clinics, but the fertility clinics are not focused on restoring function. They're just doing their part of like the egg retrieval and then what they know to do. So there's this massive gap,
correct,
which is like the place you're filling. But unfortunately, there's not that many of you. So I think, yeah, this area, we need to be operating in, I think. What are your thoughts?
Yeah, I mean, I think it's kind of a weird dilemma, right? You would think if you have more fertility clinics in the modern world, yeah, then why are we having a fertility crisis worse than ever?
Yeah.
If we have such a presence of fertility-focused doctors, it's kind of sad.
Well, because, yeah, I mean, I agree with you, but the truth that I've seen, or, how I understand it, is that the fertility doctors, they know how to freeze the eggs and then,
right,
place them back, but it's not actually focusing on fertility optimization, right? So, I mean, full disclosure, and you probably already know this because I did a whole YouTube video on it, but I froze my eggs, and, I'm interested to have a chat with you about it. I did it for the reason that I want to have a lot of kids like you do, and I got married at 32. I'm now 34. I'm going to be 35 in November, and I'm also a huge planner, like massive. Right. I want to have insurance, like as I would call it, for myself. So I did egg freezing, just one round, caught a lot of eggs and had good results. We only even fertilized half of them. That was like for really our own personal belief reasons, because I didn't want too many embryos, because I was like, if we fertilize all these and have like too many. So, I mean, I am grateful that that's an option, for me to do. If I only wanted to have like 2 or 3 kids, I probably wouldn't have even explored that. But ideally, by the way, for everyone listening, she has 6 children. So you clearly are doing what you say, practicing what you preach. And may I ask how old you are?
38.
Okay. And you just had a baby not too long ago, because you have a little one here today.
Yes.
So when did you get started? When did you have your first baby?
25.
Yeah. I mean, I wish I would have, but I didn't even have a husband back then. I was like nowhere close.
Yeah.
So
I also have PCOS, endometriosis, high FSH.
Jeez. Okay. Well,
so just, your labs don't define you. Right?
Yeah, that is true. That is true. So, I mean, I kind of went off like on a little bit of a tangent there. So yeah, for me, I wish all fertility models were like what you're doing, right? This regenerative. But then at the same point, I'm personally grateful that I was able to do that. So in the future, if I need to, I can draw upon those. The embryos we will draw upon no matter what. But yeah, so I think it's complicated. We have this massive hole of fertility that we need to be addressing, and we're just not.
That gap again.
Yeah.
Right.
And I don't know what it will take to get there, because most fertility doctors aren't thinking about really root cause at all. It's just, I don't know. It's just the way the system is, I guess, right?
Yeah, I mean, that's how in history, if you look back at history, the infertility subspecialty was started at the same time that IVF was invented.
Okay.
So they put all their eggs in that basket. Yeah. They were like, oh, this is the future.
Mm-hmm.
This is going to be the end all be all. And that happened with Clomid as well, with the birth control pill. Whenever there's anything new and exciting, we think it's going to change the world, right? That's just human nature. Like, this is going to be the end of all our problems.
Yeah. Which is never
right?
The case, yeah.
But unfortunately, a lot of that specialty, the training, is still trapped in that time. And we talked about it's hard for medicine to move forward. So
Yeah.
there's still, the training is very focused on IVF itself. And they don't really have a focus on surgical restoration, hormonal exploration. It's mainly IVF protocols. And there's actually a survey that I saw from Cleveland Clinic years ago, and it asked trainees that were learning IVF, do you wish you had more surgical experience? And majority of them did say, I wish I had more. So I think there's a lot of room and opportunity.
Yeah, we definitely, I mean, we need something in the middle there for women, because other subspecialties or PCPs or et cetera are not really picking that role up either.
Yeah. I mean,
Yeah.
they can't,
Yeah.
Americans are sick too. We are getting sicker as a nation. That's definitely part of it.
Yeah.
Right. But there needs to be also some ways, everyone wants different approaches, right?
Yeah.
They want to have different options and early access to something that they can do proactively and maybe doesn't need to be expensive, for example.
I mean, totally. What do you think, like, what could, obviously it's going to be very different for each person, but like, what could an expected timeline be? Let's say a woman is, I don't know, 33 or 34, and she is checking, following up on her cycle, not going well. The first thing that woman would probably think to do is egg freezing, right? Or IVF of some sort.
Yeah, I mean, that's the awareness.
Well, that's like how it goes at this point, right? Like, okay, but say, she wants to take an approach instead of this restorative, but time is also, obviously time is not necessarily on your side as much, even though you'd probably disagree with that, right? Yeah. So, but what we've been told is time is not on your side, because they're like, oh my gosh, at 35, your egg quality is going to drop, and it's like, that's the end.
But you know that your actual chronologic age is different than your biologic age.
Right.
So I see this a lot.
Yeah. Yeah, of course.
Right? So that's a huge thing to consider.
But are you seeing it in a positive direction? Like women are 34 but younger, or 34
Absolutely.
but older?
Both.
Okay, both.
Right?
Yeah. And you have it's malleable, right? So we know that there are a lot of things you can do about it. But what would the timeline look like for that woman? Say she's like, okay, I'm going to go into this regenerative phase.
Right.
How long do you think she might be able to see improvements in like cycle regularity?
Yeah, so it depends on the severity and how many problems. Typically, if they're infertility, an infertility patient, we're pretty far into a problem.
Yeah.
It's probably been missed by 5 to 10 doctors.
Yeah.
Right. So that's typically who makes it to me, right?
Yeah.
I don't have billboards.
Yeah.
I don't have billions of dollars to spend on marketing.
Yeah.
And nor does it pay like that. So
yeah.
When they come to me, they have exhausted all their options. Okay. So even with those difficult cases, it can take time. It just depends on the severity, but they're typically older. They typically have more advanced stage that I'm thinking of, a lot of them. Now, it's very different than a woman that comes to me at 25 with similar problems and hasn't failed a lot of things, a lot of things. So really, it's so variable. I mean, it could be just, do they just need progesterone? Is that all that it is? Is it just cycle charting? I've had one couple come in, severe male factor, 10 years of infertility. She learned how to cycle chart, I think took some Mucinex and got pregnant within 3 months.
Goodness, what did the Mucinex do?
So Mucinex is a cervical mucus enhancer now.
Oh, interesting.
For some people.
Okay.
Now, it went viral on the internet, and no one should just say, oh, that's going to do it for me, right? But it can absolutely, when we look at biomarker data, we can see extend release Mucinex improve for certain people who have low mucus. Now, we have a ton of mucus enhancers I talked about, NAC and some other things that we've done. Even amoxicillin can enhance cervical mucus, for example. So it depends on the biomarker data that we see and things that we might try.
When would you take it?
So take it during the fertile window, like when you should be having cervical mucus. So it also depends on when you typically ovulate.
Got it. Okay.
So not everyone's going to benefit from that specific supplement or medication, but there are cases where it can benefit.
Interesting. Okay. Well,
I know. See, so for example, that was very cheap. She learned how to chart, and severe male factor, was told to get IVF somewhere else and conceive, so, and then you have other people that, may never, right? I mean, there's never a guarantee in life. It's similar to a cancer model, right? Like you have to figure out all the health issues going on. infertility is a red flag that there's something else going on, a medical issue going on.
Yeah.
And it's typically on average 5 to 6 medical issues.
Wow.
That we find when it gets to the point of infertility.
Dang. So what are a few of those? Like PCOS?
Yeah, PCOS and endometriosis are common, but it could just be hormone dysfunction, ovulation dysfunction, low cervical mucus, cervical stenosis. They may just need their cervix opened up. Partial tubal occlusion or complete tubal occlusion, which I unblock fallopian tubes all the time. Man, there's so many things. Fibroids. Chronic endometriosis, infection in the uterus. Sorry.
Yeah. If you want to check the status of your fallopian tubes, aren't there 2 ways to do it? It's either an HSG, or what do you think about this other one of doing the little bubbles?
So, I mean, I guess it depends on where you are and what access you have to what. But the best, if you really want to do a thorough, I'll tell you the best. If you want you like the top tier stuff.
I do.
The best evaluation of a tube, you have to check the proximal and distal fallopian tube.
Okay.
The proximal tube is where the tube inserts into the uterus. That's where an HSG and the bubble test. I'm not a fan of the bubble test, but HSG is an all or nothing. So you're going to see the dye spill or not through that. It's basic. It's a little bit subjective, right? I mean, it's a little general. It's not going to detect issues of, let's say, if it's half blocked, it won't detect that, for example.
Got it.
So 50% of the sperm are not going to make it from that. You're going to have a big fallout of sperm at the cervix, then in the uterus, then at the tube. So you want less barriers from those 100 million sperm to their destination. You want some because you want to filter out the bad sperm.
Yeah.
But you want to open up the healthy places that should be open.
Yeah.
So the proximal fallopian tube, you can measure a partial occlusion in the tube. And what's even better is while I do that, I can use a guide wire and open up the tube.
Nice.
To optimal.
Yeah.
Remeasure and make sure it's good. Sometimes if it's a harder one, I might get a firmer wire and do it again. So it's only half the picture of the tube. I'm happy if it spills, and I'm happy if the pressure went back to normal. And I check each tube individually. This is a very precise test that I measure each tube individually.
Yeah.
So that's inside. That's only the inside where it inserts into the tube or into the uterus. Now, that's only half the story, because what else is critical for the tube? It's the fimbriated end. You want it to be free. You want it to be mobile. You want it to be able to capture that egg. So the only way, this is for people with significant issues trying to conceive. The only way to really know is with a laparoscopy and looking with the camera.
Got it.
And to see that that end is free. So should you be doing, let's say, IVF before doing a laparoscopy? I think that should be controversial, right? Because what if there's something there that we could fix quite easily?
Yeah. Yeah.
And restore that tube function.
Yeah, that makes sense.
So really, if an HSG is normal, that's reassuring, but it may not be the whole story. It may be missing something, especially if you did that and everything's normal and you're unexplained. There could be a distal problem with the tube.
I'm going to be excited though for like when we can use imaging or something for these things, because it just feels like
that's a great thing, but there's just something about looking under the hood of a car, right?
Yeah.
Like that you can't ever, like there's a mechanic. So I'm a fertility mechanic. That's my job.
Yeah.
Right? And so if there's a wire loose or something under the hood of a car, like obviously yes, but I want to be realistic too, right? With my experience, there's so much to find, to look for, and they're so tiny, so nuanced too, right? Like how can a computer know that the fimbria are free flowing? By the time you would do all the diagnostic imaging, you could do a very minimally invasive procedure. I mean, ideally, what if we could just get a really tiny camera, a teeny hole? I mean, already patients like do so remarkably well for minimally invasive surgery. I mean, women wake up from endometriosis excision surgery, and they say, "Oh wow, I already feel better than the surgery was easier." I had a hysterectomy patient with stage 4 endo, said her surgery recovery was way easier than her period. So like if you do these surgeries well, you use the laser, you're delicate, your experience, recoveries tend to be not as, it's not as, especially just a diagnostic surgery too. I mean, I know it's We as doctors definitely don't like to do it. It's not something we take lightly. But also with modern medicine, with a young, healthy population, the suffering of years of unexplained infertility, self-blame, and invasive procedures versus like IVF procedures versus a diagnostic laparoscopy. I mean, I just think it's really important that we balance it fairly, because a diagnostic laparoscopy, I look at the diaphragm. I look at the liver. Does the liver look fatty? How's the gallbladder health? How's the appendix? Is endometriosis on the diaphragm? I mean, these are things that imaging will, a few millimeters.
Yeah.
It could be 2 millimeters wide, right? And I think it's just such a valuable tool, and overwhelmingly these young healthy women do very well, and they're so happy they did it, because their biggest fear is that you find nothing, actually.
Oh, well, yeah. Well, because then you're back at square one.
Yeah. And like, oh, I wasted your time, and this is such a big deal. I wasn't worth, like, oh, it was just me. Usually they're just like blaming themselves, right?
My goodness.
But most women are so overwhelmingly happy, and they're frustrated, whatever that wasn't found way before.
Yeah.
So overwhelmingly, people are at this time in history are not offered this enough, I would say. So not that everyone wants to do it or never should be pushed to do it. I'd say the patient knows they're at peace. Yeah. But it really needs to be truly informed consent, where for now, our imaging is, we don't have imaging for the fimbria. We have none. Nowhere close. And it would be great, but we're so far from that. I'm like, I don't know. I guess I can't see it right now. Yeah. And I've seen so many things missed because everyone puts so much weight on this ultrasound that if it's normal, it must be fine. And how many times I've had a normal ultrasound and it's definitely not fine. Yeah. And me as a surgeon, I'm like, okay, everyone, like, this is a big thing. This is a big problem. A normal ultrasound is not the end all be all.
Yeah. I mean, that's a great point. Thank you for expanding on that. I think it's really important because I think, a lot of women are on the fence, including people that I know. They're concerned about this exploratory, situation, and I don't really have any context of it. So it's helpful for me to understand that, and even just hear you say that the majority of women are overwhelmingly like happy that they did it.
Yeah, and there's specific prerequisites for that, right? Yeah. So your surgeon needs to be very experienced, needs to be very respectful of your fertility, be able to identify issues, be able to treat them. I mean, and be able to not do harm, right? Yeah. Because that is a risk of surgery, and that's very important. But it really depends on your surgeon. Yeah. So no surgery is better than a bad surgery. Sometimes a laparoscopy is better than someone just doing what they can. Sometimes laparoscopy is better, just a diagnostic. But so it's a tool. Yeah. And it's not a inherently bad tool. But people have made it a dirty word because there has been a lot of damage done with potentially not becoming prepared with the experience or the tools or the mindset or a true informed consent.
Yeah. Okay. Well, that's really helpful and clear. So, I mean, it would be a surgery. If I were in that place, I would definitely have pause of who I worked with for sure, because if something goes wrong, like, it's not an area you want to really.
Yeah. And there's some women that wake up from surgery and have an organ removed, like a tube. Gosh. And they didn't consent to it, or they didn't know they consented to it, and it was implied. So it's really important to understand your rights, what informed consent is, and screen your surgeon and find people that maybe have gone to that surgeon. I did make a course for this because it's such a big problem and I can't see everyone, and I try to educate. And on this topic, I do have a class, how to screen your surgeon, like how to what a good endometriosis surgery is, information about adhesion prevention, which is more forward thinking than most surgeons are taught. They don't really understand adhesion prevention, unfortunately. It's not a part of our standard medical training either.
Okay. Well, let's get into that. Let's now move into endometriosis. So, biggest question I have, and I've not been able to get the answer for this, is why does endometriosis happen?
I think there that it's from embryologic development, but it's multifaceted, and there likely is some epigenetic component to it.
So you're saying you think it starts in like development,
Yeah. They have found endometriosis in embryo or in fetuses. Yeah.
That's so sad. Okay, just curious, not to put blame on anyone or anything, just that my own interest. Do we think that has anything to do with the environment of the womb or placenta?
I have not seen anyone dive deeper into it.
Okay. All right. Well,
but there is some data associating presence of endometriosis with trauma. So I don't know if there's some immune component from chronic stress and maternal environment, epigenetics, turning on and off genes. It's just theoretical. I have no idea.
Okay.
And of course, I want to be careful with that because I don't want moms to blame themselves if their daughters have endometriosis. I don't know. That's just a theory that I have. But there's definitely a genetic component.
Mm-hmm.
Why do some sisters both have endometriosis? Why do sometimes one has endometriosis, one has PCOS?
Mm-hmm. Yeah. Okay. All right. And then in terms of diagnostics and treatment, and, as you just mentioned, what did you call it? The adhesion.
Yeah, adhesion prevention.
Prevention. Yeah. Can we just walk through that?
Absolutely. So yeah, adhesions are in some ways worse than endometriosis. Adhesions are bands of scar tissue in the abdominal cavity, for example, for what we're talking about.
Mm-hmm.
So adhesions are worse than endometriosis because once they form, they like to reform. So prevention is key.
So let's go back to the endometriosis. So at its core, can you explain like what it is and what the symptoms kind of are?
Yeah, so I made my own 3-tier endometriosis symptom self-survey because I think everyone thinks, well, endometriosis is just severe pain or severe pain with intercourse, severe pain with your periods, or severe pain with bowel movements. It's so much more. It can be fatigue and infertility, for example, fatigue and recurrent loss, or sometimes just infertility. So I made a huge survey to demonstrate how different it is for each person, because endometriosis is tissue similar to the lining of the uterus that's growing somewhere outside of the uterus. By definition, it is not in or on the uterus.
Okay.
It's on bowel, bladder, or next to that. Could be on the diaphragm. It could be on the appendix, for example. So it acts similar to a cancer. And it can grow and spread over time. It's slow growing. So we're not talking about months, we're talking about years, typically.
Okay.
Over time, it can spread. We don't know. I think there are probably subtypes. Some may spread quicker than others. I'm not sure. But we see in more advanced cases, which we call the most advanced stage 4, they may have big balls of endometriosis in their ovaries called endometriomas. Those are the most damaging. So we really want to prevent it from getting that bad, or at least once you start to see an endometrioma, really considering them a possible surgical candidate. Because once those grow and rupture, that's when you start seeing the scarring. And then once you start having rupturing and organs start fusing together, you may have something called a frozen pelvis, for example. Because the rupture, the blood will cause scarring, for example. So earlier intervention may be helpful as far as not waiting 10, 15 years, which is the common experience in women who present with concerns for endometriosis. Earlier intervention may help prevent the severity of the disease and not only preserve those organs, enhance fertility, prevent quicker ovarian decline, prevent damage to ovaries, because if you can get it before it gets to the ovaries, you're that's phenomenal.
Yeah.
Now, finding all the endometriosis and all its various forms is challenging, and you really want to use a systematic mapping approach of the entire abdomen and pelvis to find it all. Then you want to take it out and be very delicate. So I use a laser to cut it out, try to keep the tissue nice and clean from blood, use a lot of irrigation. I use lactated Reingers because it's more body identical of a fluid versus normal saline. Another unique thing that I do, which is controversial, of course, is I take extra time and I sew the holes together. So there's open raw areas after you cut out endometriosis. Kind of like on your skin, right? You have a skin and the lining of the abdomen. And we have two open raw areas. They actually sit next to each other in the abdomen after you stand up after surgery, for example, or even once you release the cast after surgery. So those two raw areas, they don't know how to heal. There's no guiding, nothing to guide them. I mean, your body's going to try to fuse it who knows where.
Right.
And that does depend on your genetics, potentially a little bit, the inflammatory environment as well. And so by sewing those defects together, that the peritoneum, the skin, I'm guiding the body's healing process and preventing open raw areas from being sticky.
That makes sense to me,
but almost no one's really doing that.
Got it. Leave it open.
Leave it open. And so the more you cut, the more likely it's going to scar. What's the worst is if you remove a cyst from an ovary and leave the ovary open and don't even close the ovary. Some surgeons do that. And so that's going to be really sticky. And then even more so, let's say you remove a fibroid and you remove a cyst from the ovary. Those are almost definitely going to stick. So there's also other amazing adhesion prevention measures that are more common.
When they stick, so it's like then like distorting the whole shape of the ovary because it's like now went from being like this nice circle to being like
it'll be misshapen, it'll be fused, it won't be mobile, so it'll reduce its ability to function and ovulate healthily or release the egg. It'll ovulate, it may release hormones, it may be a little compromised hormonally, it may not. But the key for fertility and reduced pain is you want that follicle to be able to release. So you don't just need ovaries, you want healthy, mobile ovaries, right?
Yeah.
That's part of the function. And that's something that's also lost. It's like we need to retain function. So what we do with my fellowship, what we call nanotechnology, and a form of restorative surgery, is we called it pelviplasty, plastic surgery of the pelvis. So we reconstruct everything that we can. Tubes, ovaries, we put it back together as beautifully as possible. I want to leave it better than I found it, ideally. So whenever I do sew things together too, the sewing technique is key. What I use for suture, how I do it. I want it to look like the hem of clothing. I want it to be smooth like that and tuck in. No open, raw, frayed edges. Those are sticky.
Yeah. Well, I mean, for me, just an outsider, I don't have much experience understanding this. Feels like what you're doing, everyone should be doing. It's a bummer that it's not, but I'm glad.
They can't.
Okay.
Because the model's so broken. Well, it's not part of the training, so they don't even know that this is a thing. It takes a lot of extra time. It's not reimbursed, so it's all a cost, like a loss for the hospital, for the surgeon, currently in the current model. In fact, any surgery over an hour for endometriosis is so poorly reimbursed that it's not, you basically aren't reimbursed after the first hour of endometriosis surgery. And to be able to do a thorough advanced endometriosis surgery easily takes 3 hours. It can take up to 12 sometimes. I mean, those are extreme cases, extremely rare. But it acts like a cancer. It can literally grow on every single organ in the abdomen. I've seen that on the diaphragm, around the heart, on the lungs, in rare cases. But it's an extremely complicated disease. It really should be respected like cancer surgery and reimbursed as such. But unfortunately, most endometriosis surgeons have to go to cash to keep the doors open, to be able to keep the doors open and be able to give that service. So surgeons aren't really supported in training model or in practice model or incentivized in any way or able to even give that kind of care. So I mean, where is the draw for training? I mean, it's being done, and luckily there are, but to be able to do this on the scale that it's needed, I think it's a very common disease that we're missing a lot.
Yeah.
We really need more people to be incentivized to do this, or we really need more surgeons to be able to do this. I don't think it has to just be OBGYNs. I think general surgeons would be great for this too.
Yeah, that makes a lot of sense. So what is the procession you would see from you think you have endometriosis, maybe use your questionnaire, right? Then would you immediately go to surgery, or would you do, most of the time it's birth control, right? Like that's the general recommendation.
That's the ACOG recommendation, yes.
Yeah. So instead of that, or would you do bioidentical hormone replacement
Yeah.
first and then do surgery later, or how does it?
Right. So yeah, it really depends on the patient, right? The person, her age, the risk benefit, her fertility status, the level of severity of symptoms. I think understanding your cycles, seeing where you are in your life, and yeah, do you want to try to conceive first and see how it goes? Like, are you in a position where that's better for you? Do you have access to a surgeon? Do you just want to talk to a surgeon? Do you just want to do research about it? Do you want to do a very thorough mapping at an endometriosis center where they're doing a really good deep dive ultrasound map?
Yeah.
Those do exist. They're hard to find.
Mm-hmm.
Cost-wise, who knows? But that is the second best thing to a diagnostic laparoscopy. So I don't think everyone needs a diagnostic laparoscopy, especially if you don't have access to like a really thorough surgeon. But I think it would be helpful to do a deep dive into the understanding of what it could do, things to look for, that you are suffering, acknowledge that this is a problem, and all the different ways that you could address it. Mainly just awareness that it could be that, I think, is the most important. What goes with that? So iron deficiency is very common, and fatigue. There's so many things we can do for that. Bioidentical progesterone absolutely is an alternative to birth control that I see work very well. TENS units, pelvic floor physical therapy, lifestyle, nutrition, removing gluten and dairy for some people, for example. So it's very individualized, where you are in your life and what you want to do. Also, but talking to a surgeon that's a really good expert is sometimes an option too. It doesn't mean you have to do surgery. Sometimes it's nice just to talk to them. Sometimes you might want to do just the endometriosis mapping. I do think people get excited about non-invasive tests for endometriosis, but they typically don't add a lot to my workup. Like if someone came to me with a non-invasive endometriosis test, they're just not very reliable. I think endometriosis symptom screening is important, and ultrasound is important. Those are the two big things, and then cycle charts. That's the data that I analyze to give a level of suspicion to the patient of what I'm going to find.
Yeah.
And the better the ultrasound, the better the data you have, to make that decision for yourself. So it's really up to the person, like what they're comfortable with, and the data that they research, but really being confident with who you go to, obviously, is important. Not just going to your local doctor, especially PCPs. They don't know much about endometriosis. That's just not really on their radar.
Yeah. Yeah. Well, I mean, I think this has been an amazing, dive into all things fertility, endometriosis, PCOS. Where can people find you?
I have a website, NaomiWhitaker.com. I'm on Instagram, TikTok, X.
Yeah. Well, we'll make sure to include all the links in the show notes. And it's been such a pleasure to have you here. I really appreciate, the innovation that you're bringing into your practice, the education that you're sharing with women. Like I said, I think it's so necessary. And there aren't a lot of voices that are giving great solutions, I think. So
thank you so much for sharing this with your amazing audience. And I really appreciate you having me.
Of course, it's been so fun. So thank you again.